All right. Good morning, everybody. Thank you for joining Washington Alliance for Quality Recovery Residences this morning as we're having a special guest, Cameron Fordmeir. He is going to be presenting on crisis and diversion options across the Sequential Intercept Model. And I know I am really excited to hear about this information. So Cameron has worked in behavioral health since 2001. He has a master's of education in counseling. Cameron has been a designated crisis responder since 2010. He's also managed crisis services for Benton and Franklin County, jail and mental health, the prosecutorial diversion program, and mobile outreach team from 2015 to 2021. Currently, Cameron is the regional administrator for the Recovery Navigator program and assisted outpatient treatment with Columbia Behavioral Health, and the owner and operator of Awareness Consulting and Training. So Cameron is a board member for the Benton Franklin Recovery Coalition and chairperson for the Youth Suicide Prevention Coalition. So thank you again, Cameron, for being here, and I'll just hand it over to you.
Sweet, thank you.
Yeah.
It's always nice to have a hype person, so
Yeah.
that's cool. So there's some other we went over more of the administrative type work, but I had worked in the field since 2021, coming straight out of high school, and so I got my start in community protection group homes. And so I was working with individuals who were too acute or for Eastern State Hospital, where potentially they would be taking advantage of individuals, but if you put them in prison, they would be taken advantage of. So these are individuals who committed high-level arson, murder, sex offenses, and as an 18-year-old kid, I had to learn real quick to compartmentalize and separate crime from individual and diagnosis from individual and do all those things. From there, I went and worked on the psych hospital. I've done some case management, crisis management, and a little bit of everything throughout the direct care, some therapy, all kinds of stuff up until that administrative change. So my heart lies in direct care. And so I applaud everybody who does some form of that, especially with recovery housing. When you are dealing with individuals who are needing their basic needs met, there can come with a lot of behavioral health issues, especially while they're getting settled in that. And so some of this will be good information for you guys as we go through, because I'm assuming that, and Julia and Brooke, I will speak directly to the two of you since you're on there. If you have any direct questions on any of this stuff, don't hesitate to ask or interrupt. You can also put it in the chat. I'm watching that as well. And if you want to be on camera, you can. If not, no big deal. But I do want to know a little bit about those of you who are on, and maybe just give me a quick introduction with your name, title, organization, and what you like at a training. What do you prefer? Do you have, do you like humor, frequent breaks? Do you like concise information? Let me know what that is. And so maybe we'll go ahead and start with you, Julia.
Hi, my name is Julia Reardon. I work at the Advocates Recovery Services. I also have with me two directors and one of my house managers. They're housing directors, but we actually do a assortment of things. We have 5 recovery houses currently, and we do some peer support, FCS, and we have a housing first model shelter. So
good to see you, Julia. I'm glad that you're
Hi,
here.
Brianna.
Hi.
This will be right up your alley. There's a lot of information here that will pertain to you. So welcome. And Brooke.
Hi, my name is Brooke Bolding. I'm an employment peer services specialist at Peer Olympia. And yeah, on our trainings, I always appreciate like kind of a mix of like visual information and then kind of like following along with the whatever is being said. So yeah, glad to be here. Thank you.
Sounds good. Perfect. All right. Getting started. This meeting is recorded, and if you do ask a question and maybe you don't want that to be in the chat for everyone, you can just send it to me directly and I will bring it up without any identifying information in that. And so today, what we are going to be doing is going through some disclaimers. We'll go through the what we're going to cover today, and then we'll start with some objectives and get into the training. So again, anything that we discuss here, you are always wanting to go back to your governing bodies or your agency's policies and procedures. So this is for information and awareness purposes only. So you always want to check with your providers or your organization on what your protocols or policies and procedures dictate what you can and cannot do. So nothing that we talk about supersedes that. This training is better meant for you to understand the crisis system and the Involuntary Treatment Act, which is law for the involuntary detainment to either secure withdrawal management facilities, ENT, which is an evaluation and treatment facilities, or a crisis triage facility. I will try really hard not to speak in acronym talk. So if I do, feel free to raise your hand or ask what I'm talking about, because we also use acronyms in different ways as well. So capacity and ITA are evaluated and determined by an individual evaluator. So even though we are covering their laws, similar to how police officers have and governed by the same laws, you may get two different results dealing with two different police officers with the same issue. And so that is very similar to what we're talking about here when we identify capacity, when we identify the Involuntary Treatment Act. So I'm going to give you a guideline, but keep in mind that this is also determined and interpreted by individual evaluators. And keep in mind, again, the use of alcohol or drugs does not mean individuals are absent of capacity, meaning that they may still have capacity due to their usage, and it may or may not meet ITA criteria from that. So a couple disclaimers continued. I am a behavioral health professional, but we are not engaged in a therapeutic relationship. And so what I mean by that is there are limitations of confidentiality. So if you do disclose some things about your clients, or you do disclose some things about yourself or your organization, when it's recorded like this, or there's other people watching, I cannot guarantee confidentiality. So if you are going to send me something that you want confidential, please do it in a direct message. And then be kind to yourself, your coworkers, and the individuals we serve. A lot of times we are looking to help people, and that's why we got into this field, but you need to make sure that you are doing well. If you are not doing well, it's going to be very hard to provide quality care or be a good community partner to those around us as well. So again, try to please be on camera if you can. If not, no worries. I don't care about interrupting or asking questions. So if there's something that you're wanting more information on, or something that was breezed over that is pertinent to you, feel free to ask. And again, if you want to, you can always propose questions or comments for the group as well. So today's session, we are going to go over the Sequential Intercept Model. This is a fancy way of looking at how everything from services from beginning to somebody being in crisis to after potentially incarcerating and released, all of the services under the sun that would be available to that person. So it is a long title and a way of basically getting to the nuts and bolts of, in your community, what services do you have, and at what point can they interact with the patients or the population and the individuals that we serve. So after that, we'll take some questions on that section, do a 15-minute break, give you time to get up and get around. Feel free to eat on camera, drink on camera. I'm not really worried if you have snacks or need to go to the bathroom or anything. The other part in section 2, we will talk about capacity. And that is what frequently your first responders will determine if they can take somebody. So now with various law changes like 1310 and Blake, police officers and law enforcement entities and sheriffs are less likely to show up to crises in which they would have in the past. And so what you are more likely to get is you're most likely to get a fire or EMS and a crisis worker. And so crisis works off of the Involuntary Treatment Act, which is under RCW 7105 for adults and RCW 7134. If you really want to look those up, go for it. It's a heavy read. But the Involuntary Treatment Act covers all of Washington state. And so even though you may be in a different region and crisis providers may go about things a little bit different, the law stays the same in Washington. And capacity is what your first responders are governed off of determining whether they can intervene and actually take somebody into a hospital or provide care against potentially that person's will. So again, we'll do a quick break in there. We'll cover depression and anxiety, because that's probably the most common thing you are going to see when you are dealing with your individual served. And then we'll go from crisis, self-harm, and suicide and discuss a little bit further into those as well as how to interact with somebody and assist during those times. So objective one, when we talk about the sequential intercept model, we want you to become a little bit more familiar with the sequential intercept model, meaning what it is and what it does. This is how, when we first get into somebody's community, we are doing this currently in Walla Walla. We are sitting down with the police station, sitting down with various community health workers, trying to make it outside of just the immediate. So your behavioral health providers, your housing providers, anybody who touches that system, and map out what they have. And that's the best way that you can figure out, okay, where are we missing? What are our gaps in our community? What services do we not have? And if we did, where would we plug them in at, right? Where are our strengths, where are our weaknesses, and go from there. And that applies to each and everybody's community. So some communities have a very robust sequential intercept model. Some have 2, 3, 1, right? But everybody will have some form of crisis service and some form of first responder services. And then hopefully you have other ones that you can plug and play from there. So we're going to identify services needed in each one of those intercept models. I will go over key members that you want to include in those discussions, or at least build relationships with if your organization doesn't have one, and then maybe how you recruit individuals, you implement these, and how you track some of the data, and for who you track the data for to keep programs up and running. So let's talk about it. How many, maybe a quick raise hands, thumbs up, or you can put it in the chat. How many have ever seen this before? Nope, probably not a lot. So this is a good way, like I said, where we can say if a healthy community had all the services under the sun, they would cover in this section. So a lot of your crisis lines, your 988, your local crisis numbers, your continuum of care sit in intercept 0. This is where individuals are first beginning to be in crisis. This is the first time that we can intervene with this person and have a potentially good outcome, or we can have a bad outcome and they can move up into the other intercept point. And so that's where 911, your local law enforcement, fire, EMS responders, some people have a co-responder team, for example, that would be interacting with intercept 0 and intercept 1. Ideally, we would help the person before an arrest occurs. And so maybe we can intervene, and maybe they don't meet a criteria for a detention. Maybe they don't meet criteria for arrest, but in that we don't want it to get to that because it can always escalate if we don't intervene properly. So in those services, that's where we want to pre-arrest divert individuals potentially. Now, if that happens, and sometimes arrest does happen or it's mandatory, we'll talk about intercept 2, where we get into the initial detention and where that individual has first entered the court system and maybe gets their initial sentence, or maybe can have the ability to plead down or whatever that is. So this is in where you are actually in jail. We would like potential navigators in jail. You have your jail mental health staff. You have potential people who are doing MAT treatment, so medication assisted treatment, if individuals are coming in using opioids or some type of, there's other medication MAT treatments, right? Some people have been microdosing, some people have been using various substances. Well, we don't want them to go through withdrawals, right? Especially those individuals who are heavy users of benzos or alcohol. They could potentially go into medical withdrawal and die from that. And so you want somebody in jail who is going to at least have the ability to do some prescribing or access to those medications, and that's where they would fit in there. How many are familiar with drug court, VA court, therapeutic courts, mental health court, any of those type? So intercept 3 is where those exist. So the person is still in jail, but there's a potential to get them out of jail. And so we'll break each one of these down. I just want you to kind of look at how this is and how people flow throughout it. And people will circle back in. Sometimes they don't end up in an intercept 4 and they remain in intercept 3. Sometimes they don't come out, or they come in different spots, but this is usually a flow of how they would work. And then we have our re-entry. So you have your people who are on DOC or on some type of community service. And then this is where housing programs lie traditionally, right? So somebody could skip from intercept 0 and 1 straight to intercept 4 if they bypass the criminal justice system. But we're helping people who are re-entering as well. And so both any type of recovery housing fits into that Intercept 4 model, where you're providing a service for somebody who is either leaving prison, leaving jail, or is needing some assistance with any type of recovery. And like I said, was able to bypass jail, hopefully. So again, and then you have your Intercept 5, which is more of that community corrections, which is that monitoring of case management. Maybe they're on some type of therapeutic court where there is a potential drug assessment that needs to happen, or any type of UAs. This would be in this section. So when you look at these, this is where when you're introducing this to a new community, you would say, okay, what services do you have in Intercept 1 currently? And like I said, most people would have some form of crisis, some form of law enforcement or first responders. But do you have a youth mobile crisis team? Do you have mobile crisis at all? Do you have co-responders who also respond with first responders? That can be fire, EMS. Some people ride along with the police or ride separate. This is where we can go through all of this, and it's called sequential intercept mapping, where you start being familiar if there are services that you were not aware of that are being provided in your community. Here's where you learn about them. Or here's where you start advocating when there is grants available or funding through your counties and cities for services that you do not have for your community that you can start plugging and playing and kind of messing with from there. Any questions on this before we kind of get into each section? Okay. So moving on to Intercept 0. Okay, so talking a little bit about these, we will identify the services, and you can kind of maybe make a checklist of these services. And then let us know, or let the governing bodies know that, hey, we would like these services added. How do we get these, whatever that is? And then we will also talk about not just that, but the key members in the next slide following on who you would invite to the table and who the discussions you want. Frequently when we do this, we run in silos, and that is a bad idea when we're talking about community resources. When you only hang out with other people in the recovery community and all your meetings are gathered to that sector or to that intercept point, we're not talking to county officials. We're not talking to law enforcement. We're not talking to health districts. We're not talking to potentially other prevention elements, right? Or any social determinants of health. So when we talk about this, you want to invite key stakeholders who can actually and the easiest way to do that is we all deal with very similar problems. We may have a different skill set. We may have a different way of looking at it, but we all have similar problems that we can say, hey, homelessness, right? Addiction. There are other things that we can say, we all feel a certain way about this issue, and how can we present a different way of looking at this with a common goal of dealing either with the same population healthy, or making sure that they have a robust system in place that is going to make it a little bit better for them to have the outcome that we want. So when we talk about that Intercept 0, we talked a little bit about some of those other ones, the warm lines, which is like your, not just your 988, that's more of a crisis line, but warm lines like your talk, your text. And for kids who are using that, any type of okay to say is another one. We're getting a couple, or one in Washington that doesn't have its name yet, but it's more for bullying. These can be anything that would be in that crisis element or kind of a subset of those. So some of those talk and text ones, anything that's more available for people to help guide them and find the resource that they want. You have mobile outreach teams. Do any of you in your current communities know of a co-responder model with police, fire, and EMS, or some form of mobile outreach that you have? Crisis should be mobile, but there are specialized teams that do that. Brooke, Julia, anybody in your guys' that you can identify? Okay, the other thing we can do in here is do community education in Intercept 0, because you're going to be dealing with people who are housing providers. You're going to be dealing with people who provide rental assistance. These are individuals at Social Security Department, anybody, work source, vocational rehab, anybody who would be dealing with a certain population. We should be providing some community education to, so that they know what resources we have when it comes to housing. So mental health first aid fits in that. Any training for your dispatch, so that they can keywords when you call and you need assistance, that they're more familiar with the terminology that you're using, or that they understand the difference between when you call your house versus when a crisis triage facility calls. So on and so on. You can kind of pinpoint where different, is it temporary? Is it permanent residence? And here's the difference with what we're talking about. CIT is crisis intervention team training that's specifically for first responders, but there are also school problems. More and more, we have our ESD and 2 other behavioral health providers who have put counselors in schools. And when I mean counselors, I don't mean the type that check your schedules and make sure you're doing it. They actually provide some therapy and med management. So other school programs like YARP, Youth Assistant Resource Programs, NAMI is another one that fits in here. So your National Alliance of Mental Illness and any type of homeless outreach. Here in Benton and Franklin, we've actually paired up our recovery navigators, which is a peer-based live life experience, individuals who are going out either to help with the criminal justice system or the addicted population. And they're paired up with law enforcement and DCR, designated crisis responders, and they go out and do homeless outreach. They're not looking to get people arrested or get people evaluated. They're looking to provide some resources and kind of be out there and do more community involvement and community police work versus more of a criminalization or authoritarian approach to that. And so there is no agenda other than to get people some water, make sure that they're know about their resources if they want, get them some food, etc. In the wintertime, they'll go out with blankets and scarves and hats and all different types of stuff too. So homeless outreach also falls into that Intercept 0. So if you don't have any of these things, here is who we need to talk to. We need to get chiefs, sheriffs, commanders, captains, and local law enforcement, okay? When we're looking at big level stuff, you want to make sure that maybe it's just one that you start with. Maybe you start with a police chief or a sheriff that you have access to or that you can see at other meetings. And then they have the contacts with other city members that they can start inviting to the table or other law enforcement. Here in Benton and Franklin County, we have 10 different law enforcement entities, and that includes the Pasco and the airport, which when I first started this, I would have never known to include those individuals in our discussions because I had no idea, right? So once you get into speaking with law enforcement, they can kind of identify the other key players in that. You also want to include your dispatch. And so hopefully when you are in areas that cover multiple counties or multiple cities, hopefully you have one line, one CCOM or one dispatch that you can work with. If not, identify who those other dispatchers are and invite them to the table as well. You have your crisis responders, your EMS and fire. A big one for anything to start is to get your city council members or county commissioners. If you do not have buy-in from your city, a lot of cities have enacted a 0.1% that is specifically used for behavioral health services. If you are identifying services that you don't have in your community and you would want them, the county commissioners and the city councilmen, the people who have at least control over those sales tax, they can use that money to provide a service that you don't already have. So they're definitely people that you want to bring to the table when you start having these discussions. Again, this is your opportunity to say, hey, we all have family members, friends, patients, individuals that we deal with who have substance use problems. So does city council, right? They don't want homelessness for other reasons. So we can identify common areas that they don't like, and maybe we can present those as solutions when we start talking about these additional programs. So again, other housing programs that we can refer to immediately and divert from jail. We have advocacy groups, you have school board members, other community trainers when we talked about having that basic needs. And then your 211, your clothing vouchers, food assistance, anything that we could help somebody with when they first come out. A lot of people that enter into homeless programs or housing programs or any type of assistance have basically nothing, right? So if we can get them some toothbrushes, we can get them some soap, we can get them some socks, get them that random stuff that people really don't think about, or at least hook them up with basic needs providers that can do that. That's going to be very helpful as well. So then we have Intercept 1. Now this is specialty stuff, where you have law enforcement co-responders. So those two individuals in that picture with the vest on are mental health clinicians. And so they will respond in tandem to behavioral health emergencies in the community. If there is a call that comes through specifically with key points that CCOM has been trained to recognize, whether that's symptoms of mania, maybe that is some type of severe depression, whatever, somebody that's suicidal, they're going to send the squad out that has the 2 designated crisis responders that follow along with them. So these are your co-responder models, your mobile crisis, your any type of specialty. Some people have CIT trained officers, community paramedics fall into this. Any pre-filed jail diversion options, meaning that if you have somebody who committed a crime, but you have a pre-arrest diversion policy put into place, we can utilize that immediately without having to jail this person and start the whole thing over again. So that is who fits into that category. And when you have those discussions on having either specialized law enforcement, co-responders, or any type of variation from that, you definitely want the police, sheriffs, and patrol officers. And why I included patrol officers in there is they are the boots on the ground, right? Chiefs and sheriffs may be able to have the say-so and the calls in that on what they do, how they implement it, but patrol officers are the boots on the ground. They're going to be able to tell you in real time what would work, what wouldn't work, what they prefer. Do they want somebody to respond in tandem, meaning in a different car, or do they want that some person in the same car? Maybe they want the service line, but they don't want them. They consider their police car their office. They want them available to them at the police station and can be dispatched separately, or a fire and EMS station, right? So again, you have any type of directors, VPs, CEOs, any type of clinical supervisor of the teams that you're going to merge with law enforcement or fire EMS. You want your county and city prosecutors in that. If you do not have a relationship with your city prosecutors, believe me, they want to know what is available to them. City prosecutors, their dockets are getting full and more full, especially with this last round of legislation, and Blake is now a gross misdemeanor for possession charges. Prosecutors are going to get flooded and jails are going to get flooded, especially if you don't have these options in this intercept point of diverting people before they get to jail. It isn't a good experience for those of us who have been in the criminal justice system. And if you could potentially have that interaction diverted with, and it's not a get out of jail free card, there are stipulations there too. But if you are less likely to be affected by the criminal justice system and directed to a service line that is more appropriate for that, the better. And then again, we also want dispatchers in there, because you want somebody to be able to say, okay, how is this team going to get out there? How are the individuals in the community? How are the individuals in the recovery community or recovery housing? How are they going to get a hold of these teams? Is it a separate number? Is it through 911? Is it through 988? This is something that you have to decide with the key players in your community on how that call gets sent out. So then we have Intercept 3 in here, and this is for the initial court hearing. So this is with somebody who has been arrested. Maybe they were presented with a diversion option. They chose not to take that option. There are some people, I have a cousin like that who much prefers to be in jail. He enjoys people telling him when to get up, when to eat, when to work out, and when to go to sleep. He likes that in society a lot more than he likes his freedom of choice. But there still should be services available if he ever changes his mind. And so this is when they get into that initial court hearing. You want to have some screeners. You want to be able to identify that, hey, I don't think this, even though maybe the rest at the time was the best option, this person looks like they're signs of mania or psychosis, or maybe they were under the influence when they committed some of the crimes that they were alleged to commit. Then we want to be able to have somebody who has training outside of a correctional officer who can identify those and make that recommendation that maybe we should go this route, or maybe we should look at a furlough order for this person, which is something that you can do legally and get that person sent to a psych hospital, a crisis triage facility, a detox service, and then they can come back or be just let free once that stay or once that stabilization occurs. So again, that's where we talk about the crisis system partners. Are you partnered with jails, crisis units, psych units, et cetera, so that you know, hey, we're calling, we want to stabilize this person, they can return back. We're going to arrange transportation from a correctional officer from jail and return back. So psych hospitals are more willing to do that. This is where you would have your clinicians in jail to do behavioral health trainings for law enforcement. Some correctional settings have the sheriff as their backing, others are private, and so they have their own chief. So you find that out, get to know those people, and provide some potential free behavioral health trainings or resources for the staff. They do love that, and a lot of those trainings are mandatory that they have to have. So become a partner with the jail. You're more likely, if you've worked in an SUDP, that maybe you're doing and already had a role where you would go into the jail and assess for that. So there's plenty of opportunities for community partners to partner up with jail to provide some services that they don't already have. Again, you want to partner with a jail medical team, especially for MAT treatment, but also just to check out people's physical health and make sure they're doing okay. We don't want any deaths in the jail. And so if you have people in there who can help identify medical emergencies or behavioral health emergencies before they occur, that is ideal. And then again, any type of prosecutorial diversion program. Why that is a little bit different than therapeutic courts as we get into the next one is that the prosecutorial diversion program, you don't have to be sentenced to. You can potentially, if competency has been raised, and it doesn't mean that that person is competent to stand trial, that means competency has been raised that they are so either one under the influence or so gone in a behavioral health emergency that they don't know and understand court proceedings. We can get somebody who has that out, assessed, and provide some case management and other services for an individual like that without having to go through the entire court system. So when you have these, first people we need to get on is, regardless, most jails are run through your county or a city. Right. You get into privatized prisons. I don't know too many privatized jails. So when we start talking about, hey, we want to get people in Intercept 2, we want people to have the ability to provide services in jail. First people we need to bring to the table is your county and city prosecutors. If they're not willing to divert those crimes or willing to have a therapeutic court who would potentially do that, it's going to be null and void. You're not going to be able to do it without the county and city prosecutors on board. You then need judges who are going to understand those options and support those options. Usually there are judges who are assigned specifically to these specialty courts so that they become kind of experts in that field and know exactly the process to use and how to get somebody from point A to point B. And then you're going to want to have your correction staff there. You're going to have individuals, they do not, and they don't want to be mental health professionals. They have their job. They're worried about their own safety. They're worried about inmate safety. And they don't have the degree or the training to be a social worker or a behavioral health professional. People who would do those jobs for them. Type of screeners in there that already exist or new ones that would be providing the service. So if you don't already have behavioral health screeners, you would be inviting your local behavioral health agencies on who would be willing to potentially staff that or supervise that position. And then you have your administration from partnering facilities, like we talked about. When you get somebody who has a partnership with a psych hospital, they don't think that it's weird that you're calling them. A designated crisis responder usually calls me. The ED usually calls me. It's like, now the jail's calling me. Well, they know that we have a furlough order or somebody who needs further stabilization, and then they can come back to finish their jail stay. So you want to include that administrative in there. And probably any and all behavioral health providers that are in your community should be at that table, because you can have multiple people doing multiple things. And for example, you could have one agency who just specializes in the med management section of that. You have another agency who staffs the designated crisis responders who are in jail, or a master level clinician who can do the assessments. Maybe you have another agency who only works with peers and has peers in there. So you can potentially have 3 different agencies in that one jail, all providing behavioral health services, just different service lines and for different purposes. So you want to bring everybody to the table when we are talking about implementing those type of service lines. So Intercept 3, we have jails and courts in this section. So here, that is a picture of Benton County Jail. So this is a mental health clinician who is getting the rundown, and when somebody either first come in the jail and they have identified that there is some drug and alcohol issues or there is some behavioral health issues, they'll get put on a list. Now they either get brought down for people who have already been in jail and presented that way throughout, or they first came in that way. Either or, they will get put on an observation, and usually a mental health assessment will be either first thing or afterwards attached to that stay. So this is where we want your mental health, your drug, and your veterans courts, your therapeutic courts. This is where you can expand upon possible diversion programs too, that we didn't get them on the first way in, but we can get them on the way out. You have your jail behavioral health services, which can do one-to-ones with individuals. Sometimes recovery houses will come in and present groups to inmates. So for discharge, they'll present coping skills. Maybe you have a jail prescriber, either an ARNP or an MD. You can partner with the psych hospitals, the ENT, and these are primarily, like we said, for furlough orders. So that is something that if your jail is unfamiliar with, these are where we have that discussion of what about furlough orders. They do furlough orders for medical. So if somebody has something stuck in their abdomen or digestive problems that they can't take care of at the facility, they do furlough orders for medical. So there's also furlough orders available for behavioral health treatment too. So again, we have MAP. I won't death by PowerPoint. You guys can read on there, but these are all things that fall into Intercept 3. So when we are talking about Intercept 3 and how we implement those, we want to identify those key community members. And again, right away, that's going to be the people who are affected first, and that's going to be your correctional officers and your jail administration. If your jail administration and correctional officers don't want it, think it's an issue, it's going to be really hard to implement these programs if the people who are running the jail or monitoring the jail are not on board. And so that's where we want to speak to their strengths too, because like I said, they don't want to be the ones who are doing counseling. They don't want to be med prescribing. They have other jobs that they want to make sure that they're safe and that the inmates are safe so everybody goes home to their families okay. This is where we have the administration for the courts. So VA court, drug court, mental health court, or any variation of that. You're going to want your crisis and commitment services. So both ITA courts, you want your designated crisis responders. This is where you want your prosecutors, judges who would actually be the ones doing the furlough orders. If you can get a template down and everybody knows what it is, it just becomes a plug and play where you insert your name, the patient's name, check off a few boxes on what partner you went with, and they're going to the psych hospital, they're going to the secure withdrawal management facility. Once you set one up, it becomes very easy to do from there. But the hard part is getting everybody on board and developing these forms. And that's where we want these people and these key players to do that. And then we have our jail mental health teams and jail medical teams. Sometimes they're not the same people. So sometimes they're ran by different organizations, but that's where we want to make sure who is everybody providing services within jail, and let's bring them in as well. So then we have re-entry. So entry Intercept 4 is where you have jail behavioral health teams and transitional case management. So typically when somebody is leaving jail, we want to make sure that they have at least some basic needs met. They have housing in place, or they have a resource to go to obtain that housing voucher, or can actually apply for housing. Ideally, you have somebody who is helping with that discharge or that release plan to do that. Maybe there's a crisis triage center that you can discharge somebody to where they can stay up to 24 to 3 days. And that person then can have some additional assistance outside of that. So the worst thing we can do is just discharge from somebody from jail to where they go right to the gas station, start drinking again, and they're back in jail that same day at 3 p.m. when we could have sent them to the right spot or had a little bit better of a plan put into place so that that person has a more likely outcome of success than not. And then so for Intercept 5, this is also where we have your DOC ORCs, which is your intensive case management for individuals who are coming out of prison, and then sentence alternative options as well. So key members for Intercept 4, these are your transitional case managers. These are your crisis triage facilities, your evaluation and treatment facilities, anybody with the county or the health department or Social Security who may handle benefits assistance. For those of you that know, and maybe you don't, when you are put into jail, your Medicaid is suspended. And so if you don't have somebody who's assisting with that or knowledgeable of that when they get out, they're not going to have the ability to pay for the services that they once did, when it's a lot easier now than it used to get terminated and you had to reapply. So at least that has been fixed, and that is different, where they just become kind of in limbo or they're suspended and waiting for them to be reenacted. This is also where we want to get private landlords involved or specialty housing. These can be Oxford, your missions, transitional housing, any type of group homes. Everybody needs to be an Intercept 4 at the table so that everybody who's either bypassing the criminal justice system has access and knows what housing available to you in your community, or you're partnering up with your jail so that they know too, and the clinicians in jail, that when you get released, these are available to you. As most of us know, if our basic needs aren't met, if we don't have the ability to provide a roof over our head, know when our next meal is coming, it is extremely hard to stay stable, unstable, if we don't have these things put into place. So sometimes housing and recovery housing gets lost in the shuffle when we start talking about this, but it's a vital area of the sequential intercept model, is that housing and is that recovery, some programming attached to that, to make sure that people are going to be able to get their physical health and their behavioral health taken care of. If they don't have a place to rest their head and they're worried about safety and basic survival, it's highly unlikely that we can get anybody stabilized or sent in the right direction. So then we have key communities in there. You have your DOC orgs, your outpatient case management, and your outpatient treatment teams. We could probably even circle back and grab those immediate or those co-responder teams and know, hey, we had individuals that you eventually saw in this, they're now living here, right? So we have, you're not violating HIPAA or giving too much information if it has to do with continuity of care, or the person's willing to circle back to those individuals too. So just make sure that you're following the governing guidelines of what you can and cannot do. But if these individuals are already being monitored by a behavioral health provider and you are the housing and recovery type of center that they're in, there is a natural continuity of care that we can get releases of information so we can keep going back and forth with those individuals on updates or coordinating care. Now, recruiting. How do you recruit for these specific roles? And this applies to recovery housing as well. So for one, it is always ideal to have some direct care or some type of live life experience. If you do not have the experience or the passion for it, it is extremely hard to be effective in that. And we want to recruit people who know what it's like to potentially be homeless or know what it's like to have a substance use disorder and have problems in multiple areas of their life. So any type of live life or direct care experience is important. You also want people who are self-motivated and confident. It is extremely hard to make any difference if you stay siloed and you're not comfortable stepping outside of that and working with the rest of the system in play. And so you want people who are going to be able to speak up for themselves within reason, right? We don't want to become aggressive or confrontational and then create a separation or animosity for another system partner. But we do need to be somewhat self-motivated to get out, get there, and make sure that we are seen and that you're understood on where you're coming from a certain issue and how these other type of system partners can help with that. We also want individuals who are clearly understand roles of staff in each intercept point. You don't want to be that person who has an opinion about something that you don't actually understand or know about, right? And that is why we're doing a lot of this for agencies or programs who have historically been underserved in that, so that you have a better idea of what is the challenges that the other systems go through and where are the potholes and loopholes and some caveats that is really hard for anybody who is outside of the system to understand. So we want people who clearly understand roles, people who understand each expectation of those roles in each intercept point and knows when to kind of stay in our lane and when to venture off and make polite suggestions in other ones, right? So we also know when and how to advocate. I have been in situations where we have partnered with advocates, but that same advocate had a style of throwing people under the bus or in community forums or commissioner meetings, stepping up to the plate and publicly bashing individuals. We are all here to help people, right? And so when you come out with that approach of bashing certain organizations, positions, any type of thing, you're isolating yourself. That is not a good way of advocating for the people who need the services and need the help. So we've got to know the proper way to do that and the proper avenues to do that. And typically pointing fingers and name calling any type of that way is a quick way to get ostracized out of that. Okay. Again, we want people who know how to pick and choose their battles. I can give you a recovery housing story of when and how to enforce rules, right? I'll give you one from, we had a co-occurring program and a housing program here when I was a designated crisis responder. And this individual broke a lot of curfew rules. They also were not supposed to be using NyQuil and other things that could be abused, mouthwash, etc. And they had purchased those items, right? So the staff member and this individual after curfew kind of got into it. And so wanted to make sure that, hey, right now, they're not going to be hitting the street, right? So let's talk about this. Let's wrap it up for the night. Let me talk to the person. I'll de-escalate them. We'll put a plan together. I'm assuming that you can't make any immediate decisions and you need your supervisor and manager's approval before you come up with any type of consequence or next step. And she verified that. So I talked to the individual, I get them to calm down, let them know, hey, and it just happened that I knew the individual as well from direct care, so I could speak to them a little bit more in specifics. And just let them know, hey, they're not going to kick you out right now. Go upstairs, get a good night's sleep, come back. You can plead your case on why you were late. You can also plead your case on the items that you bought and why you think those were necessary and that you didn't bother checking with the staff to do that before. And we'll go from there. So let me talk to your staff again. So I get the staff on the phone. We discuss the plan. Everything's fine. As that person is walking upstairs to go to bed, the staff member chooses to say at that time, and in the morning, we'll see about all of this, and it would just spark the person up again. And now the person's yelling and screaming, and we get another call at crisis. Not really a crisis issue, but there was no other way, or at least services available at 3 o'clock in the morning to help de-escalate. So that's where, I mean, pick and choose your battles. If it is something that is better suited to the morning, wait till the morning. If it's better suited to be handled by a different profession or position, let them handle that, right? So we have to, as advocates, and when we're recruiting people, we want people who are going to be in this field who know when to pick and they know when they need to step up and when they need to assert a boundary. And they also know when power struggles are happening and to turn that down, okay? We also have to recognize our professional lanes too. And so even though we know and want to advocate for our patients or our individuals we're serving, we have to recognize what professional lanes we are in and what someone else is in. So when you are looking at expanding programs or you're looking at getting into other programs, keep in mind that these are the type of people that we are going to be looking for to fill those positions. Again, implementation. So if you were going to implement any of these into your community, you want to train to that specific intercept model. If you are a community that is lacking in housing and recovery, you want to find people who are doing that field training, that instructor training of those. Identify those people and have those trainings be specific to that intercept model. Same thing as if we are looking at Intercept Zero and we want more youth mobile crisis. We want more peers that are on a crisis team. We want to have these different things. We need to find specific trainers who are already doing that model and have the best practices put in place. The worst thing you can do is try to reinvent the wheel when there's already best practices put in place by the state or some other governing body. Like CROA is a co-response organization agency. And so they already have best practices for those things. They acknowledge the crisis responders. So there are going to be these other entities or organizations that you're don't have to duplicate the work, and you can kind of piggyback off some of the things they do. Be able to tell you, here's what we learned in the first year of our program. Here's what we learned in the second year of our program. Here's what we wouldn't do again. Here's what we would do if we had a magic wand. If we had unlimited funding, here's what we would have done. If you get donations, here's how we would use them. There are so many useful things of reaching out to people who have already performed a service line that will save you a lot of time and headache in that. Again, there's also an embedded culture, right? So if you have people in there, when you're implementing them, you want them to kind of be the individuals who are, if they're not in that position of leadership, they can be a natural leader for people who are getting into the field. And you're mixing certain populations of, I have this many years of experience with people who have no years of experience. And at least that person can be there, that you're not starting up a program and you're putting people with zero experience with people with zero experience, right? So we also want to include your administrators, community partners in those. The other thing, what you have to do to any of this is prove your worth. Majority of the people, and I'm sure you're thinking the same thing, you hear about all these great resources, you hear about this and that. Well, if you spend any extended time in the field, we become a little bit jaded on certain things. We also become a little bit jaded and competitive when it comes to other agencies who provide the same thing. So if you are trying to implement new services, and that's something that you're doing, or that the individual, the first thing they have to do is prove their worth. And what that means is when, for example, if you call crisis, that you know exactly what you're calling crisis, you know exactly what crisis can and cannot do, and you have very specific stuff laid out so that when they know, oh, when that recovery house calls, they know what they're talking about, right? Or when you say we're willing to take people out of jail, or we're willing to take people off the cuff from drop off, or whatever that is, that when somebody does and tries to utilize that line of service, that you are there to provide that, and you've proved that you can actually do what you are saying you do. We hear so much about, here's what we do in the community, here's what we do, and then you get the boots on the ground who are trying to refer to that program, and it didn't work out quite the way they said they're going to do. People will naturally stop referring and stop including you in those if you can't back up your mission, or you can't back up what you're actually there in the programs. Again, is get direct feedback from pros and cons. This is not the time for people to be upset and getting mad. This is the time that you do share your frustrations with certain areas and system, and get an honest feedback, from either the people who are, or the system, people who are governing that system can provide. Maybe there's a law, maybe there's a system problem. And rather than just not only implementing service lines in that we can work towards fixing that system problem as well. Hold regular and quarterly meetings. Sometimes we can do too many meetings, but if you're not staying on it, people will become out of sight, out of mind. So if you're not, remember our housing program, remember what we have here, remember what we can do, people are going to eventually forget about that, right? Some programs are grant funded and time sensitive. And so that's the other reason why we want to make sure that we are letting people know that, hey, we are permanent, or we're here for this long, here's when we need to extend. Have all those so that you can expand upon your initial goals into permanent goals. There's several programs who are available for pilot programs who, once you prove their success, you can expand upon those, or the funding becomes permanent, right? So make sure that you expand upon your initial goals and that you can prove that what you're doing is working. And then again, always promote internally and externally. Okay, sometimes we get so siloed that we only speak to the people within our field, and we're not speaking to the people who still affect our system and still interact with the same people. They just do it in a different avenue. So always promote internally and externally as well. So data, this is where it is good for you to keep records. The problem with this is, what do I track, right? So everybody's going to say, well, we want to track the normal client identifying stuff, but there are sometimes grant requirement specifics that you want to make sure that you are, or that you're collecting data that will qualify you for grants in the future, right? Then we have contractor requirements, whether you are contracted with an MCO, whether you are contracted with a private pay provider, however you are contracted, you want to make sure that you're meeting those contracted requirements. But it is never a bad idea to go above and beyond those contracted requirements. So when it comes down for renewals, you can say, but look also what else we did. And is there any way we can get these type of things permanently funded, right? You have program specific measurements. So if your program is to provide housing for individuals, how many individuals are you housing, and how did that affect the entire system? Did you prevent this many people from going to jail? Did you prevent this many people from being homeless? Did you also refer to this many people for basic need items, additional services? There are so many program measurements that you can say hey, not only from a humanistic standpoint did we help this person, but we also provided these expanded services that they wouldn't have had access if it wasn't for this program or this intercept point, right? So outcome measurements are important. You also want individual staff productivity and performance. If you have staff who are going above and beyond, but you don't have any way of tracking that or knowing that, you're going to burn the staff who are doing a great job out when they're either up with somebody who's just doing the bare minimum to meet that job requirement. So you want to find a way that when you are tracking this stuff, that you can identify those people who are doing a great job, and also identify those people who maybe we need some coaching and we can do some intervention on to help bring them up to that level. And if not, then maybe they are creating problems for the individuals in the house, or maybe they're creating problems with other staff, and we have to address those as well. But if you have no productivity or performance measures, it's going to be very hard for that data to actually be applied in a good way. And then consumer outcomes. If you're not doing any type of self-assessment or upon discharge or upon intake, those questionnaires, that is a good way to figure out, are we helping the population that we're supposed to be helping? Now, remember, sometimes expectations are expectations and sometimes perceptions are perceptions. So this is not for us to get upset about. This is for us to get an unfiltered thing on where we can and cannot improve, right? So again, you're also going to have, when we are presenting to any type of governing bodies, especially county commissioners or city council people, they want to know about the cost savings. How does your program save the system money? How does your program save the county money, right? So all of these things are going to be in your favor when you can say, well, when you spend 800, just throwing a number out there, 800 on this individual for housing, you're potentially saving the $2,000 ambulance ride. You're saving the however many thousands of dollars that jail stay would have been, because the average jail stay is 14 days. They went to the ED, which is a $2,000 bill. They would have went to the psych hospital, so on and so on. You can start naming these things that you bypassed, that they're going to say, okay, that is a general cost savings, not only from the humanistic standpoint, but our tax dollars or our local funds are saved in great ways. Time savings is another one. Okay, so if you can present something that maybe I can't quantify in a cost, but I can cut down on officer overtime, or I can cut down on the doctor's time, I can cut down on all these people's time by just setting up a spot where we can have an open door or a drop-off center, whatever that is perfect. People will love to know that, hey, I can cut down on overtime pay, or I can cut down on unnecessary waiting and sitting at the ED, or waiting and sitting for crisis, or whatever the different times that we would be waiting for individuals are. And the other one is sustainability. You can actually prove that your program is sustainable, that you have some metrics to go off of, and that comes to permanent funding or additional funding, that you can say, hey, we have a model now that is self-sufficient. How can we expand upon that to meet the needs of other areas? And then use that exact same model to get that one up and sustainable. So any questions before we take a quick break for your first hour? Sequential intercept model, a long way of saying, hey, here are all the services that you need. Maybe a little bit confusing, so feel free to ask any questions, type them in, come off camera. I'll give you a little bit to think about it. All right, we will take a quick break for you guys that are on, and then we will get back with section 2. All right, so 11:15, we will get back going. For those of you that are on there, if you wouldn't mind turning your cameras on, and we'll talk real quick about your experience with the current crisis system, or your experience with calling 911 when it deals with the individuals we're serving. As I know from working in the crisis system, if you're a crisis worker, you're used to getting yelled at from multiple people from multiple fields. If it's not the law enforcement officer, if it's not the individual being evaluated, if it isn't the doctor at the hospital or the person who thinks you took too long to get there, somebody is upset. So the crisis system usually gets quite a bit of flack. So I just wondering if anybody has any specific experiences they have had with their crisis system or use of 911.
Yeah, so I've kind of learned you have to use very exact and specific language to actually get like a non-police responder, which like kind of feels like answering a riddle when you're talking to dispatch sometimes. And so I appreciated what you said about specialized training for dispatch. And I'm interested in that kind of learning like what to say to get who you want to respond to come.
Yeah, you're absolutely right. Because if you're not saying what falls under or what peaks that thought bubble in somebody, then you potentially are getting a different one, or they're trying to analyze what you're saying in a different way that they think is inappropriate, or who knows, right? So this section is going to be there that we are talking about the law. We're talking about terminology. We are talking about definitions. So we are going to talk about ways that you can take what you're seeing and be able to kind of regurgitate that or convey that in a way that either your dispatch or your crisis system is going to be able to understand what exactly you're calling for. So let's get into it. So this section, we want you to become more comfortable with determining capacity. Now, is that your job? The answer is no. But if you can understand a little bit more of capacity, you can understand when to call for emergency assistance and what they can do with that and how to speak to that, kind of like we were just talking. And you also have a better idea when to walk away and refer out, just to make that referral and be on your way. Make sure that you conveyed it to the best of your ability, make sure that you documented it, and then it's not on you. It's not your liability. I think too many people tend to think, well, I will be responsible. Well, you won't be responsible if you conveyed your concerns and you documented your concerns and you don't have the power to act out whatever it is that we were wanting to do. And if the powers that be are saying it doesn't meet criteria or I'm not doing anything for A, B, and C, that liability has removed from you, right? The opposite would be if it was true and you chose not to call, then maybe you could make that argument that liability is going to be not on your side. We'll also have a better understanding of the Involuntary Treatment Act because this is law. And I think a lot of times people think, hey, this individual is suffering or I'm seeing these symptoms, I think they should be detained. The crisis system still has to operate just like the criminal justice system, where there has to be something to why they're intervening. So what is it that's breaking the law? Or how does that fall into the criteria? That same process will get played out in court, just like it does criminal court, where a judge, a prosecutor, a defense attorney will all look at the circumstances and either kick this person loose or commit them further for further evaluation or assessment and treatment based on the information that's presented. So it's important that we know that. We also want to be able to understand the basic definitions and criteria for that, okay? The other thing to understand is bad decisions. So I put in here that substance use and mental health symptoms by themselves do not determine capacity or meet ITA. The best way I can make this understandable is we are allowed to make poor choices in our society. If I eat McDonald's every day, okay, is that going to put my life in danger? Probably. Is it going to be the best health decision? Probably not, but you can't detain me for that, right? You can't say, well, this person is not eating healthy, they're damaging their health. Therefore, people are allowed to make poor decisions, just like people are allowed to smoke legal marijuana. They're allowed to take prescription pills. They're allowed to drink alcohol. Those poor decisions by themselves are not enough to get somebody detained. So we'll talk about how those poor decisions potentially affect the criteria and how you can make that argument versus just saying, well, they're not doing stuff the right way, or they're not making good decisions, so on and so on. The other thing that we can talk about too that is not very well understood by a lot of clinicians or community members, volitional control. So we'll give you the definition of that and talk about that. And we'll also recognize key terms that may signify, like we were talking about for your use of dispatch or calling your crisis, what actually signifies and how to recognize a chronic mental illness or a severe substance use disorder. And that will also trigger when it's time for us to refer to an MHP or designated crisis responder. All right, so getting into this. So a quick myth that we hear, okay, and so this is for capacity is going to be determined by your first responders, your fire, your EMS, but it's important for you to understand, so when you are needing that assistance, you can speak to these type of things. So here are some of the myths that we hear. Decision-making capacity equals competency. That is not the same thing. When we are talking about capacity, they're not the same thing as competency. So somebody can not have capacity and still be competent. Somebody cannot be competent and still have capacity as well. So the two don't equate. So when we are talking about competency, it is not the same thing as capacity, okay? So the other one is against medical advice equals lack of decision-making capacity. Against medical advice, we do that all the time. Everybody does it, right? You leave the ED before you should. You don't follow up with a specialty provider that you were given. You don't take the recommended amount. You don't finish the antibiotic. We do all types of things against medical advice, but that can still be that we have capacity, and our choice in the matter is just because I don't follow up with what the doctor or what the clinician said, that doesn't make it so where the person doesn't have capacity. So even if they are supposed to be taking their meds, they're choosing not to take them, even though they are supposed to be taking care of their wound care, but they're not. That doesn't equal decision making. The other one that we run into quite frequently, there's no need to assess decision-making capacity unless a patient goes again. That is not true either. We can make that decision to get the person assessed for a variety of reasons, okay? So I don't want you to think that we don't do an assessment or make a request either, only if the person is going against medical advice. You can make that for a variety of reasons. Maybe they're going with medical advice, but they're also delusional. They're hallucinating. You know, they're having command hallucinations. There are other things attached to it, but they're still following medical recommendations. So cognitive impairment equals no decision-making capacity. You can still be impaired, and this could be due to a head injury. This could be a pre-existing traumatic brain injury. This could be damage done by excessive use. This could be individuals who are under the impairment of drugs or alcohol. So cognitive impairment does not equal no decision-making capacity as well. So lack of decision-making capacity is permanent. That is not true. If somebody has at one time, maybe they've become stable, maybe they've made better life choices in the recent time. So it's not static. It's not going to stay that way forever. So somebody could have lacked capacity at one time. Doesn't mean 2 days from now, 3 days from now, 5 minutes from now, who knows, that they won't. So it's not a permanent condition. And all patients with certain psychiatric disorders lack decision-making capacity. That is especially not true. Some of the most brilliant people or talented people I've ever seen have a psychotic disorder. You know, they've been diagnosed with schizophrenia, but they can see the painting in their head, and they have the ability to draw it on a canvas just off the ability in their mind, right? Or somebody is neurodivergent and they can recall all the things that they are super interested in. They know everything from Marvel, they know everything from Pokemon, they know all of the elements in the elemental system, right? But they struggle in these areas. So again, certain psychiatric disorders or issues have nothing to do with the person being able to truly lack capacity. Again, is all incarcerated or all institutionalized patients lack capacity. That is also a myth. and only a psychiatrist or a psychologist can assess decision-making capacity. That is not true. We can all do it, and we can all be able to convey that to the powers that be. So when we're talking about capacity, these are the things that we want to avoid thinking completely before we get into it. So what is actually capacity? So those of us who are nerds like myself and you want to know the actual law to look up, when we are determining capacity, that is under RCW 7132.110. So if you want that, feel free to check that out. And what that tells you is that capacity is a person's ability to make a decision. In a medical context, though, or in a crisis context, that refers to the person's ability to utilize information about their illness or propose treatment options and make a choice that is congruent with one's own values and preferences. So this also goes to cultural stuff, right? If I am somebody who does not trust Western medicine, for example, you can present that as an option to me, but me necessarily wanting to go a different route, maybe I want to use CBD, maybe I want to use a holistic thing, maybe I want to use a completely different and new thing that most people don't understand or even believe in, I still have that ability to do that, and that doesn't reflect on my capacity. So again, in a medical context, we want to make sure that the person is able to utilize the information that's available to them and then make the decision based on that availability with their own values and preferences in mind. And we'll talk about how do you distinguish between whether somebody is delusional, paranoid, versus they want their own values and preferences, right? In a Native American culture, if you're talking about hallucinations or visions, well, one is very prevalent in the community or that nationality to go on vision quests or have a different understanding of what a hallucination is. So we have to understand, is this something that we're talking about pertinent to their culture, right? The Day of the Dead in the Hispanic cultures, you would think, oh my God, this person thinks they're communicating with dead loved ones. They are definitely in trouble. Well, is it, proper in that culture to do that, and that's something that they're celebrating, and that's what the expectation is, that they have the ability to do that, then that's within their own values and preferences. So it's very important to know one's culture when we are assessing capacity or we're assessing somebody's mental stability. So the other one is medical decision-making capacity, is the ability of a patient to understand the benefits and the risk of and the alternatives to a proposed treatment intervention, okay? So capacity is the basis of informed consent. The person needs to have informed consent on what you're saying. So if we are presenting options to the individuals in our house and we're saying, hey, I can call a crisis, we can call the text line, we can do all these things, but also, is there other options before we get to that? Do they have a diversionary activity? Do they have a crisis plan? Do they have coping skills? Do they have access and availability to everything under the sun? And are we allowing them to make the best decision possible and how they want to handle that? Now, if we are going outside of that, and that gets the next step up, that is where we're calling and establishing somebody else to come in. If the person's unable to present any of those options, or it's so bad that they're catatonic, so on and so on. And we'll get into some of those more examples to where it makes a little bit more sense to us. And so not only must the patient be informed of the options that are available to them and the decision free of coercion, right? So you'd say a lot of times I'd see designated crisis responders say, well, the option for you is I can detain you or you can go voluntary. That's not really an option free of coercion. That means that you're going regardless of what happens. So I'll allow you to make the decision in it, but the decision's been made that you're going. That is a hard way to frame that it's not coercion, right? Hey, you'll get this by force, or you can be willing to do it. That's not the same thing as here are the options. Feel free to pick which one. Okay? But the patient also must be able to have capacity to make that decision. So again, if we are establishing capacity, we have given them all of the information available to them, what services, what course of action we think is going to be appropriate. That person needs to be able to have the freedom to make that without coercion, but they also have to have the capacity to make that decision. If the person is not able to make that decision, or they are so in a state of depression or still in a state of psychosis or still in a state of intoxication that they can't make this decision at all, then we are making that for them. So capacity, when it comes to fire and EMS, so when you are calling, you're typically going to get a first responder that is not going to be law enforcement unless there's a crime that's being committed. So when we are talking to fire and EMS and CCOM or your 911 dispatch, we want to make sure that often care of the patients where decision-making capacity falls into question. This includes, but is not limited to, the patients who are dealing with depression, psychosis, dementia, stroke, personality disorders, developmental delays, comatose patients, and those using alcohol or drugs. So for them to make that determination of capacity, fire EMS have 4 categories that they need to look at. We're going to discuss all 4 of those, okay? So the 4 key components to address in a capacity evaluation include communicating a choice is number 1, understanding that choice, being appreciated. So appreciation is 3, and then 4 is interchangeable. Sometimes people call it rationalization. Some people call it reasoning. So we just put them together, rationalization and reasoning. These are the 4 areas that we are going to be looking at the individuals in our house to make sure, okay, this is probably something that we probably should call 911 and see if convey that to the responder, if they're seeing the same thing that we are seeing. So for communication, the patient needs to be able to express a treatment choice, and this decision needs to be stable enough for the treatment to be implemented. So I'll give you an idea based on kids, and we'll put it back to her, right? The best option for treating children, especially those who are in housing programs or in child long-term inpatient placement, or just your own kids or other people's kids, is to always present the options, right? So I need you to clean your room. If you don't clean your room, here will be the consequences, okay? I gave the action, the course of action that we need to happen, and I gave all of the potential consequences that could occur. The person can pick, though, right? Now, doing nothing isn't one of the options that we gave them. So the options are very clear, and I'll give you another example in a treatment setting on how you would get into a power struggle versus communicating somebody's options to them. When I supervised the crisis triage facility, it's called Transitions, we would get staff who would be trying to implement programming, but they would frequently get into the power struggle versus setting limits. So they would get mad and say, hey, you're my supervisor. You keep telling me I'm getting to a power struggle, but you also keep telling me to set limits and expectations. So which one is it? Well, how they were going about it is saying, you will go to group or I will kick you out of here. Well, if you talk to anybody like that, you're probably going to get a middle finger because nobody wants to be told what to do or how to do it, right? So that is a good way to get into a power struggle with somebody. Do this or I'm kicking you out of the house. Meet this expectation or you're gone. That is a good way to get into a power struggle with somebody versus explaining a part of being in this house or a part of being in this program is attending group, is doing chores, is cleaning up, is doing something, right? Here's what the expectation is. Is it that you don't want to be here and you'd rather be somewhere else? Or is there something that we need to discuss or an area of concern that you're having that isn't being addressed? Because the expectation is that you will go to group if you want to be here, or you will do your chores, whatever the expectation is. You give the person to say, yeah, I don't really like group. I don't really like chores. I don't like to do this. I'm actually better at doing this kind of stuff. I've never experienced this before. Whatever rationale they give you, that is better than giving them an ultimatum of saying, do this or else this will happen, right? So are we giving somebody their options and are they able to communicate those options with us? So changing one's decision in itself would not bring a patient's capacity into question, just as long as the patient was able to explain the rationale behind the switch. So if they show up and they say, hey, we can take you to a crisis center, we can take you to the emergency department, we can take you to things, and at first they say yes, and then they say no. But then the rationale is, well, I have group tomorrow that's court ordered. I have this obligation with my DOC officer. If I go and get checked in, I'll get fired from my job because I've already been late several times. I have these other obligations. I'm supposed to meet my kids, so on and so on. If there's an actual reason why they did that, you're allowed to change your mind in your course of action too, even if it was already agreed upon, if that makes sense. Now, if it's the fact that little green men are coming and meeting with me tomorrow, or that the TV told me that things are going to happen and the Armageddon is coming. If the reason is more delusional in nature, then we know, okay, communication is called into question here. Checked out for these reasons. The other one would be frequent changes back and forth. If the person's so undecisive of whether they need help for their wound or whether they need help from their substance use and they're going flipping back and forth, we're just going to err on the side of caution in that case. And we're going to say that area of competency called into question. And we need to call either a designated crisis responder or fire and EMS for that. Feel free to interrupt and provide examples, or if you have any questions, feel free to stop me at any time. So understanding is the next one. That patient needs to recall, and what are you calling individuals in your house? Either I use individual serve, patients, clients. Some people get upset about those terms. How are you referring? Are you referring to people in the house as residents? What is the proper way to refer to individuals that are in the recovery housing that you're serving?
Yeah, I always refer to them as residents.
Okay.
We refer to them as members.
Okay, members, residents. Okay, I will try to use that interchangeably in this. Anybody else use a different term? Okay. So when we're looking at the understanding, the member needs to be able to recall conversations about treatment. So for example, I can say, hey, in this situation, we can either take this PRN medication, which is available to you. We can call somebody for medical treatment. We can take you to this place. We can call this agency to come, and we don't have to call a designated crisis group. We can call a mobile crisis unit. We can call somebody else. What did you hear me say? Okay, that person, if they're able to recall the options back to you, that's the best sign right away that they're understanding. Okay. But then we want to take that a little bit step further, and we want to make sure that there's a link between the current situation and the cause of the problem. So if that person says, hey, do you realize that your continued use is causing these medical complications? If they can't create the two, that my sores, my liver, my kidneys, my whatever is being affected by this continued stuff, if they think it's due to a vaccine that happened to them when they were 3 years old, or if they think it's due to radio waves coming from the atmosphere, if they can't link it to the actual cause, that is another check that they're not understanding. Okay, so we want to make sure that we are able to recall the choices that we're giving them, but also that they're able to link the actual situation with the problem that's causing that. The other thing is we want to be able to process probabilities of the various outcomes of their decision. So if they're saying, I know that if I take this medication, I know that if I get treatment, I know that if I do A, B, and C, I am this much likelier to have a better outcome, but I don't care. I'm going to go with the 0 one. Okay, then at least they understand that, okay, you know that you're agreeing and you have these options put into place, and these options would have a better outcome statistically, but you are still choosing to do the other one. That is going to be where we can say, okay, the person is just making poor choices, right? That is one of those situations that is unfortunate. They know the consequences of their actions, but they are choosing to eat McDonald's every day, knowing that that's going to cause other health issues, when they know the probability of having better health outcomes would be eating your daily servings of vegetables, fruit, blah, 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 right? So there's also potential problems with memory, attention span, ability to communicate, and intelligence that can make it difficult to assess one's understanding. So what that means is we need to understand, if we're dealing with somebody who's had a head injury and their moment of lapse is that 15 minutes of recall, we don't want to hold that against that person for a pre-existing issue. People who have Alzheimer's, dementia, developmental disabilities, traumatic brain injuries, so on and so on. We want to be aware of the members who are in our homes, that we know that their medical issues or that their past substance use isn't being called into question for the ability to understand. So again, we just want to make sure that we know their background, know their medical issues, know their history. For appreciation, this is the member's ability to identify the illness, the treatment options, and the likely outcomes as things that will affect them directly. Okay, this is where you get into the people who are delusional, hallucinating, maybe have some magical thinking that, oh yeah, I understand all of that stuff. I'm able to tell you the probabilities, but that stuff doesn't affect me. I don't have a heart. I have 3 hearts. So I'm not worried about that. I don't breathe air the same as you people breathe air. I have this ability. I can read thoughts, so I don't need that. If they start giving you outcomes that aren't directly related to them or it directly affects them, they're somehow above that, unaffected by that, but they're able, then they don't have the appreciation element of that. So a lack of appreciation usually stems from a few areas. One of those is going to be the intelligence level. Okay. Person lack of capacity to understand based on their intelligence. Do they have an IQ score that qualifies them for developmental disabilities? Do they have other impairments in their intelligence, so on and so on? Okay. And emotion. Person making poor decisions based on the intensity of their emotions. Are they doing what they're doing right now because they are extremely agitated? They're extremely stressed over all the stuff that's going on in their life. Are they really mad at somebody who triggered them or said something? And if we give them a little bit of time to calm down, they'll make the better decisions. And we all know people like that. Then if I'm in the moment, you tell me, hey, this is going to happen. I'm like, I don't care. 5 minutes goes by. I'm like, oh, I probably wouldn't have done that. I don't want to do that. I wouldn't have done that if I was in my right mind of thinking. But when you see red or you're that upset. So is this being called into due to high intensity? They just got a phone call that their review didn't go well. Their assessment didn't go well. They didn't get the placement they wanted. They didn't get the job they wanted. They had a loved one who got hurt or worse, right? So is what's going on directly related to the situation, that high intensity of that emotion? And can we wait a little bit and reassess to see what is happening once they've calmed down? The other one is delusions, that the patient is not affected by the situation in the same way and will have a different outcome, right? They've been given us special abilities. They are chosen ones. We hear that quite frequently when religious preoccupation comes in, that, yeah, but that won't affect me because God has talked to me and he's given me this ability and that ability. I can do A, B, and C that doesn't affect the rest of you, but sorry, you guys are all out of luck. I'll be fine. You have to look that one, because people can understand consequences, but not apply it to themselves. This is the area that where we're going to look at appreciation being affected. And the last one is going to be rationalization or reasoning. So the resident has to be able to weigh the risks, benefits of the treatment options presented, come to a conclusion, and keeping their goals and best interests as defined by their own personal set of values. So they can easily be able to go through the first 3, and then we get to this point where, okay, they have understood what that is. They were able to recite it. They were able to go through all the probabilities of what is a better outcome, all of these things, okay? But am I making the conclusion that makes sense, still keeping my best interest and my goals in mind? Now, we can't fault somebody for knowing all of these things, again, making a poor decision, but that poor decision directly affects their value system, right? Maybe they don't believe in the criminal justice system. Maybe they don't believe in mental health or behavioral health. Maybe they don't believe in medication. So it's not the fact that they're delusional. It's the fact that personally, they don't put those things in their body, or they don't want to be involved in that type of system, don't agree with whatever it is. This is where we have to make sure the rationalization and reasoning is in part. So areas where you may experience this the most are patients who are dealing with psychosis. Okay, they're going to give you something that is a hallucination, and they can be a couple different hallucinations. And I'll give you a off-topic but cool thing that you can help understand where psychosis and hallucinations may be stemming from. If somebody is telling you something that is an auditory, so hearing, or a visual hallucination, seeing stuff that doesn't exist, those are typically mental health related. If somebody is telling you they are smelling stuff that doesn't smell right, or they're smelling sulfur or things in there, or they're tasting, that is typically a brain issue. So there's something that happened to the head. Maybe they slipped, fell, hit their head, something happened. They got something else going on in there. If it's tactile, meaning on their skin, and they feel like itching or stuff is in there, that is typically drug related. So when we're talking about hallucinations and psychosis, we want to make sure if we're gathering some of that information that we're getting what are the hallucinations of and what may be the course of action. Like I said, somebody who has organic schizophrenia and lives with that typically doesn't have tactile hallucinations unless they're using something like meth, right? So that will help you kind of dictate what is going on and maybe the course of action or that information that you relay to the first responder that is responding. The other one is going to be depression. They don't care. They understand, they're checked out, they've had enough, they're not dealing with this stuff. So the rationalization and reasoning could be there, but they don't care for enough for it to be there. They're at wit's end. Same thing with anxiety. They are too overwhelmed, too restless to sit down and think about it, whatever that may be. Other ones are phobias, which aren't as bad unless those areas are there. So if you have a phobia to clowns, hopefully nobody shows up as a first responder dressed in clown makeup, then we'll be okay. But now, does that person have a phobia to needles? Does that person have a phobia to, the outside world? Whatever it may be, the rationalization and reasoning will be affected because people will try their hardest to not get that issue present for them. The other one's going to be delirium and dementia. Okay. So for anything that's affecting that person's cognitive ability to make the rationalization or the reasoning argument. Any questions so far on this? Is this important for determining capacity? Well, at a minimum, we want to become familiar with these standards so that we can actually improve the ability of the patients who lack capacity, right? We want to be able to understand these things so that we can convey them better, and we can also help with the person. So maybe that doesn't rise to the level of us calling law enforcement or calling the crisis system or calling our first responders, and we can help deal with that on our own. It also helps us understand and applying the defined markers most often provides sufficient capacity in itself. So if you are worried about it, if you've gone through those 4 steps, you make a better case of whether you should call or you shouldn't call based on you knowing the markers for that. And so we also have to understand that just like psychosis isn't static, what I mean that somebody could be, but it's not a straight line. It doesn't happen all the time. People can come in and out of that. So decision making could be temporary. It could be within 15 minutes. It could be an hour. So we have to realize that it's not static and that sometimes it requires more than one assessment or more than one assessor. So there are also certain factors such as infection, medication, time of day, and relationship with the person who's doing the assessment can also affect capacity too. So it may be a staff member that they don't like. It could be a time of day they don't like. It could be an anniversary day. It could be something that if we do a little bit of background info or asking fewer questions that go into that area, we'll be able to determine that, okay, this isn't a capacity issue. This is stemming from the fact that they had a divorce in August and August is coming up, or a death of a child, or, a trauma occurred on this time. So it may be something outside that we're not really thinking about too. And so if the decision can be delayed until a time when the patient can reach capacity, this should be done in order to maximize your residents' autonomy. So if it's not dealing with immediate danger issues, or it's not something that we need to interact now, time is on our side. We can give time a little bit. Like I said, let that person go back up the stairs and go to bed. We'll address it in the morning. Maybe that's a better time to address some of the stuff than to give them, an earful on their way up to going to bed. Okay. So other considerations, we want to try and be thorough with our documentation. What type of documentation are you doing for your members currently? Are you documenting meds? Are you documenting daily activities? Are you documenting therapeutic interventions, groups? What type of documentation, if any, are you doing?
Yeah, each house is different, but usually they'll have some sort of programming in place where they are documenting how many meetings they went to, if they attended this self-help class, as well as some of our operators and with Walker have the recap system, which will actually determine their recovery capital. So they actually do assessments and stuff on them with certain programs. So
Cool.
Yeah.
So
We track like the meetings, the meetings that the people attend, IOP, like Brianna said, self-help groups, but anything they're doing for the recovery, if they relapse, then what they do after that, volunteer work. And then we connect them with FCS or peer counseling, things like that. And then we track when they're meeting with them as well.
Gotcha. So the one thing that I want you to think about too is when you are documenting when it comes to 911 or first responder approach, have some form, whether that is in your regular notes that you're using, or if it's somebody who's becoming a little bit more that you have a separate one. I don't really care how that goes, as long as you are documenting that I called on this date, spoke to this person, right, officer so-and-so, or I spoke to the designated crisis response or Susie, whatever that is, about these issues, right? So you want to document the reason why you called, what were the circumstances of that call, and that you also want to document the disposition and the follow-up of that, so that not only can you make
understand why I tell you to put the stuff you put in.
Yeah. So we want to make sure that we're building a case to where if this continues, and I've had to call tomorrow, I have to call 3 days from now, I have to call a week from now, that we have a running dialogue of narrative that we can say, hey, I know that you guys gave A and B reasons for this, but this is a continued issue and it's getting worse. And I've spoke to this person, and this person on these dates. That carries a lot more weight than it is we've called so many times. Well, to who? Well, I talked to so-and-so. Okay. If it's the first time that person's getting your call and you don't have that other issues that you can reference or times that you called, it's going to carry a lot more weight when it says, okay, this is the third time we've called 911, and this is the third time that we've gotten this house. However, these things are in place and they're also still causing problems, right? We've done A, B, and C in an attempt. We're at wit's end now and we need assistance with these areas. So these are stuff that you should be adding to the existing stuff that you're documenting or creating a separate one for that. So the next one, you're referring to mental health professionals or designated crisis responders. We want to do that when it's particularly difficult or high stake cases that may involve legal proceedings. So if this person is court ordered to do something and we are standing by watching this person further aggravate a existing charge or potentially get them other, we want to call, especially if that person's capacity is called into question and they're doing things that could further their legal involvement. The other thing we want to do is make sure that we're calling in cases where significant substance use or mental health affects the patient's capacity. So now they're not able to understand, they can't appreciate, they can't go through all of the rationalization with us. We're calling now. Okay, the other one is that we want to call when collateral history is necessary to better determine capacity. And what I mean by that is that if you have a patient who has a history of being incarcerated, has a history of medical emergencies, has a history of crisis services or hospitalizations or withdrawal management stays, these are things that we also want to call and verify or at least have at our disposal so we can show. And I'll get into that when we start talking and switching gears from the first responder system to the crisis system on why you would do that, because it's not imminency, it's likelihood. And we'll give you all that other stuff as well. So switching gears, any questions before we get into the Involuntary Treatment Act, which is what crisis handles, versus determining capacity, which is what your first responders are going to be doing? Okay, all right, moving on to the Involuntary Treatment Act. So for those of you that are taking notes and love to look up stuff, ITA law, which is the acronym for the Involuntary Treatment Act, is covered under RCW 7105, and that is for adults, and then youth, which is 7134. We'll give you a little bit of breakdown on other slides, but I just want to remind everybody that you cannot detain anybody under the age of 13. The crisis system can help you. So those of you that are handling youth and adolescent type services, 13 is the magic number for age of consent for treatment. It's also the number of age that one can be detained at. So anybody under the 13, you have to help with family or parent initiated treatment. So Before, when we're talking about recovery housing, prior to 2018, it used to be chicken or the egg. Well, I'm not going to detain your resident because they're under the influence of drugs and alcohol, and it isn't depression. It isn't A, B, and C. It's this. There is no chicken or the egg comment anymore. Did the person get so depressed that they started using substances and developed an issue and an addiction with that? Or were they so drunk that they couldn't function, started losing relationships, and became depressed? We don't have to worry about making that argument anymore. It's either depression, it's either suicidal ideation, homicidal ideation, regardless of reason. So substance use disorders were added in 2018 to that criteria. So now it's a behavioral health in general criteria versus are they mentally ill or do they have substance use problems? There is no more of that anymore. So that has worked quite a bit in our favor. Evaluations have to be done by a designated crisis responder to determine, as a result of a mental disorder or that substance use disorder, that there is likelihood. Now, you will hear eminence, okay? You will hear, well, that's not eminent, it's not happening right now. But is there a likelihood, and I will give you the definitions later on here in a few other slides, that the person is a danger to self, they are a danger to others, or they are gravely disabled? You can be all three, but they have to at least have one of those, and we'll expand upon those in order for be detained. Now, for assistance, we can call anybody out, anybody who is a mobile outreach, anybody who does community outreach, they can be fines, but in order to get somebody detained in Washington State, the only one who can do that is a designated crisis responder. So the IT evaluations, typically those evaluations go through dispatch, or your local crisis agency to request a DCR evaluation. However, anybody can make those requests. A shop, a family member, a house. It doesn't have to go through an emergency department, nor does it have to go through dispatch. You can simply, as a community member, call it if you're worried about somebody and they fall into these criteria on what that is, okay? But I am going to give you something that has probably made you mad and the rest of the community furious as well on the crisis system. So law requires that designated crisis responders consider any and all least restrictive alternatives to prevent or prior to hospitalization. Now that means voluntary placement. They could go to a crisis triage facility. They can go to voluntary withdrawal management services. They can go to crisis triage facilities, whatever, peer crisis respite, anything treatment related is a least restrictive alternative to psychiatric hospitalization. So you can do safety planning. There can be jail diversion programs. You can do referrals to outpatient services. Basically anything is safety planning with loved ones. Anything is a least restrictive alternative to hospitalization, and a designated crisis responder has to prove two things. One, that least restrictive alternative has already been tried and doesn't work for whatever reason, or that is inappropriate use for whatever reason. Meaning that if I was sending somebody home with the boyfriend or girlfriend that they have that is also the one who has a DV case and contributing to this, I'm not going to send that person home with a safety plan with that person, even if it's the only person that we can safety plan, because they were partially the reason, if not all of the reason, why the individual is in crisis in the first place, right? Or we're sending them back to a trap house that just sold them all the drugs that they were using that got us here in the first place. So you either have to prove that alternative has been tried and doesn't work, or it's inappropriate for the current situation. So IT evaluations continued. When you are calling a designated crisis responder, sometimes those hours take, or the evaluation takes about an hour to 2 hours to do. Sometimes it can be a little bit sooner depending on how well they know the person, but there are several things that have to be included in those. And a lot of them are probably what you're already, or your agency has kind of schooled you up on documenting too. So they're looking at the person's mental status, their current mood, how well their affect, and does that affect match their mood, or does it match what's going on in the environment? If there's a lot of sad things going on, but they're laughing, that's probably a good sign that they're not doing well, or vice versa. If there's a bunch of scary things going on and they're not responding to that, there's serious things going on, they're not responding, there's happiness going on, but they're looking sad and looking flat affect, whatever that is. If the facial expressions are not matching the mood or the scenario, that's one way. The other one is hallucinations, delusions, and thought process. rate, rhythm of your speech, volume of tone, and then grooming and hygiene are also good to include there. If it is the summertime and your resident is putting on 3 winter coats, a hat, and there could be some other issues there. One is maybe they're not regulating temperature very well, and that could be a part of their diagnosis, or maybe they're not doing well enough. So are they groomed and appropriate too for situation and for time of weather is another thing. And then when we get into the big ones, suicidal thoughts. We have all in this room had a suicidal thought or know somebody that's had a suicidal thought. So it isn't the presence of a thought that is the immediate concern. It is what you are going to do with that thought. Do you actually have a plan, and have you gone as far to write it out or convey it? So do you have a specific plan that you've put into place that is also coinciding with your thoughts? Do you have intent to follow through with that thought? And do you have means to carry that out? Okay, or do you have a history of doing that same thing that we are talking about? These are the areas outside of just simple thoughts, because I could tell you, oh, I don't want to live anymore, but I don't want to wake up. That's different than saying I am going to take pills to ensure that I don't wake up in the morning versus me conveying to you how I feel. Oh, I just wish I'd get hit by a bus. Well, am I going to jump out in front of traffic? Am I seeking that out? Do I plan on doing that? Is different than using the words to convey how I feel or how I'm doing. So we really want to include outside of thoughts, are there plans, intent, and means associated with those imminent danger issues of self or others? So the exact same thing applies to homicide. I can just say, oh, I just want to kill you. Or I could just punch something. Well, are you going to? Do you actually want to hurt somebody else? Or are you just describing the level of frustration you're having, right? These are clarifying things that we can talk with our members. And the other one is grave disability. Has anybody ever heard of grave disability or even understand 100% what that is? You can either show of hands, thumbs up, whatever that is, because there's not a lot of clinicians that fully understand grave disability as well. So we'll talk specifically about grave disability. I do want to show you, I won't death by PowerPoint, you can read all of these, but I do want to bring your attention to a couple other ones. Intellectual developmental disabilities, okay, or medical diagnosis. Those by themselves aren't criteria per se, right? So for example, if I have a 6'3", giant, strong, nonverbal autistic kid, the diagnosis itself isn't qualifying for the criteria. But if that kid is continuously bashing his head into the wall or continuously trying to cut themselves, continuously trying to put their head in a door frame and close it. These are the criteria that they're doing, not the diagnosis that is causing it, right? Because otherwise the psych hospital is going to say, we don't have meds to cure autism. We don't have meds to cure developmental disabilities. We don't have meds to cure that. That is not what I'm asking you to do. What I'm asking you to do is to maintain their safety level, because they're doing an activity that is putting them directly in danger to self, danger to others, or they're gravely disabled for these reasons. So it is not the underlying diagnosis or intellectual impairment. It is the actual acts that go with that, if that makes any sense on how you clarify that. The other one is volitional control, right? And good faith voluntary status. We'll talk about volitional control, but I do want to bring your attention to those two things, because those commonly get misconstrued or caught up to where it's like, well, how do you mean that this person with autism or Alzheimer's and dementia doesn't meet criteria? Well, if the person with Alzheimer's and dementia is showing up on other people's doorstep and they've had a gun pulled on them 3 times because they don't seem to understand, they don't live in that house that was 20 years ago, and they keep being, that's the act that's putting them at danger or affecting other people's life, not the dementia, not the Alzheimer's, right? So let's talk about grave disabled here. Here is the definition if you want the legal definition, but I will give you the easy Cliff Note version to understand the difference between danger to self or grave disability or what that means. So if I'm up on the roof right now to jump off and hurt myself, that is danger to self. If I'm up on the roof to prove to you that I can fly and that I have magical powers or I have a mutant ability or whatever, that's grave disability. So another one would be if I have no other way to lose weight right? And I think that, hey, I'm just going to fast for multiple days. I'm not going to do A, B, and C. Maybe it's not the best decision. That's my own personal decision versus if I am not eating because aliens have poisoned our water supply and tampered with our food supply, or told me that this is going to occur and that all of us will be poisoned, that's grave disability. The other one is just poor choice, right? So that is how we're going to determine grave disability, is due to that substance use, due to that level of intoxication, or that mental health condition or behavior. Are those the reasons why they're putting themselves in danger, or are they aware of what's going on? They're just making a poor choice. So gravely disabled, can you differentiate the two by danger to others by based on, am I actually up here to cause problems for people or hurt myself? Or am I doing something like being naked? There was a gentleman who we have a canyon here in Benton County as Zentel Canyon. He was running naked through Zentel Canyon. Well, if you're just streaking and you're doing that, that's a different issue. That's a criminal issue. If you're running through because you're naked and there are people chasing you and there was stuff on your clothes and you're running through, well, if you run into somebody, and I have my kids with me, and you're a grown man running through this thing and naked, I might draw down on you. You might have a bad interaction with somebody who's also walking their dog, or heaven forbid they're by themselves, so that action is putting that person at danger due to their mental condition, not based on the poor choice. And that's how we would say, okay, that's gravely disabled. Any further questions on that, on how you differentiate between the two? You guys are making this very easy for me. Okay. Feel free to come back to. So now we want to talk about terminology. How many of you have called crisis and they say, well, that's all fine and dandy, but it's not imminent. It's not an imminent danger issue, so therefore we can't do anything for you. So when we talk about imminency, we are talking about a state or condition of likelihood that occur at any moment or at near hand rather than the distant or remote future. So what that means is that a lot of times people will say, well, it sounds like it's pretty bad, but it's not bad enough. And you're saying, what do you mean it's not bad enough? I have to wait till they try to kill themselves for you to come out and assist me. I have to wait for them to do something bad. I have to wait for a criminal activity to occur before you'll respond and help me. And sometimes the answers that you'll get will be yes, but that does not mean, okay, that there are not other avenues, and you can speak to this with intelligence and speak to it within reason to the law. But yeah, that may be true that it's not imminent, but that doesn't mean it's not likelihood. And we'll go through some of those too. But that's what imminency means. So when you hear somebody telling you that there is no imminency, that's what they're referring to. The other one is going to be substantial adverse effects. Okay. If for whatever reason, that means significant and considerable negative impact on the individual. There are times when detaining somebody could be worse for that individual. Now, that may be due to financial reason. They need that job that they are to pay for their fines. If they don't pay for their fines, they go back to jail, right? Or they have a supervised parenting plan. They have something, they have a different obligation, either personal, financial, or professional, that if we put them in the hospital, that is going to cause them existing problems. So maybe they get the issue stabilized, but when they come out of jail, now they have other issues that they have and the fallout has occurred. So we have to weigh out whether this hospitalization is going to be beneficial for the person, or we are going to cause that person further problems, right? And if that is the case, are there other areas of those least restrictive alternatives that we can utilize instead of resulting to that one that's going to worse off the person's ability to maintain a healthy lifestyle or employment or whatever that is, or sabotage a relationship? So this is important for you to know sufficient environmental controls. And I'll give you a very far extreme example so you can make a little bit more sense of this when we talk about that. Substantial environmental controls are in place, okay? That means that a person is receiving or is likely to receive such care from a responsible person as essential to the person's health and safety of others. If they are in your home and they are your resident and you are making sure that they get their meds taken, you are making sure that they get their food, you are making sure that they get all of these things, or they're an adult child, or they have a significant other who's providing this. Whatever the scenario, if somebody else is able and willing to take care of those basic needs that is preventing them from doing that, that is a least restrictive alternative. Now, why that makes people mad is they're saying, well, what if I'm not there? But you are there. You're in your program. So if they get kicked out, if they choose to not comply, if they no longer want the adult caregiver or whoever else applying that, and now that decompensation occurs, then you can make the case that, okay, so this is where parents get very upset that, hey, my child is being taken care of by me. I'm the only one keeping them stable. If I'm not here, they're not going to. That makes a lot of people mad that are saying, I need help, I need assistance, but you're saying because I care about the person, I'm keeping them safe, there's nothing that you can do about that. The only place that does not apply is in jail. You can't say, well, jail, the correctional officer is getting them their food, waking them up, giving them their meds, so I will leave them in jail and not better suit them to a different environment where their needs will be met. Jails are the only place that a least restrictive alternative does not apply to. Okay, so another example of substantial adverse effects, when I called 911 one time, I was with my client who got 911 called on him. He was trying to tell them, do not put me in handcuffs. Do not put me in handcuffs. And he would only repeat that over and over, but he didn't say why. Why would you not put me in handcuffs? So the officers, by policy, if they're going to take anybody for questioning or transport anybody, they're going to put them in handcuffs. Well, nobody wants to admit when bad things have happened to them, especially to strangers, let alone to law enforcement, that they had severe abuse issues as a child where they were put in handcuffs and they were repeatedly assaulted over and over. So if anybody had that bit of information, you can say those are substantial adverse effects on the person. This course of action will be worse for the person because now when they put handcuffs on him, he was fighting them. So then he got roughed up, got additional charges. Later on, we had to present that evidence on here is why that happened. Here's why they don't want to be put in handcuffs. And the excuse was, well, they didn't tell us that. Okay, so sometimes we may, as staff, have information and we have to weigh out whether giving that information is going to present less or more harm on the person. And in that situation, I would have rather the people who were involved in that conveyed that to the law enforcement entities or designated crisis responders, whoever it may be, and deal with the embarrassment or the other versus getting taken down, getting roughed up, being put in handcuffs, and now having I just assaulted police officers. Now I'm going to court for that. Then it would be just to admit there was some abuse in the past. The other one is going to be volitional function. So this goes, for example, is if everybody responds differently to certain environments. In your house, they may be the big dog, right? So they feel like I am the resident who's the alpha male here or the alpha female. I'm going to be the barking orders. I'm the senior one here. I'm going to tell people what's up. Person's going to have a different presentation as if you put them in with a bunch of other people like them, and now they can't behave the same way. So that is an extreme way or a different example of presenting what volitional control is. One, I'm the big dog, I can do and say whatever I want, and then you put me, and I'm now a big fish in a small pond with a bunch of other big dogs, and now my presentation changes. Okay, so that's one way outside of giving you these other examples on how volitional control means. Same thing in the jail when we would do these trainings for correctional officers. If you get somebody who's throwing up gang signs, popping off in all these areas, but then you put them in general pop and they don't become the same anymore. They're not as tough as they once were throwing up those signs. They have volitional control. They have volitional function. They know when to turn it off and when to turn it on, right? They know when they can get away with it and when they can't. That is what volitional control is. So if somebody is using their symptoms for manipulation purposes, which can happen, we have to take everybody's stuff as face value. But one way is if I'm telling you that I'm hearing voices, but if you do A, B, and C, I won't hear those voices. That's not how voices work. They go up in intensity, so you hear them very loud, or they go below and you still hear them, but they're not as bad and they can still function, you don't get to turn them on and off based on whether they have a substance, whether you give them what they want, whether you provide a different environment. That's not how that works, right? So if somebody is telling you that I am suicidal, but if these conditions are met, I won't be suicidal, that person has volitional control. If somebody is truly psychotic, they cannot turn it on and off. If they are truly suicidal, they don't get to tell you they want to die, whether you give them this or you give them that, or this person's in their life or not. They don't have volitional control if they remain that way. Same thing with depression, anxiety. We can apply this to all situations. So we need to really worry about our members when they don't have volitional control. If they are going to be that way, regardless of options we give them, regardless of situation, that is where we need to worry about it. Volitional control simply means that I can either, one, manipulate the situation, get what I want, and then that issue isn't there anymore, or I know that it's a good idea when to behave this way and when not. So we really need to worry about those people that don't have volitional control. Questions before moving on? Okay. So likelihood, okay. Here is where long time of calling crisis is not imminent. You would hear that over and over. It's not imminent. There is a likelihood category. Now, there have to be some other things put into place for this to fall into likelihood. But the other one would be the A through D here. I won't read those to you. You can read them while we're talking. But the other one is that they have a history. So if I know that when Susie starts talking about being a missionary, or she starts being a prophet, or she starts doing A, B, and C and getting messages from God, even though that's not eminency, what led to that happening was a cascading effect of decompensating. And then Susie ended up in the psych hospital. If I already know that, there is a likelihood that that could occur, because here is where it started last time, and here's where that went. If it's already been on paper that they've been arrested, they have been to secure withdrawal management, they've been hospitalized, they've done all these things, you can make a case that it is likelihood, right? So that is one don't understand, or a lot of individuals don't know, that if it falls outside of imminency, there still is likelihood that this could get there. And here is why I know that. Here is the information that I have that would lead me to believe that even though this doesn't right here lead to imminency, it leads down here to imminency eventually. That is where we want to make the case. This person has a history of violence. This person has a history of hurting themselves. This person has a history of being delusional, responding to command hallucinations. And so even to you, that may not seem that big of a deal. It is a big deal 2 days from now when that person, gets to a point where they need to be hospitalized again. If we could get ahead of that, let's do that. All studies show that anybody who has a manic episode, a psychotic episode, any issue like that, you can do permanent damage to your brain, just like it happens when you get concussions in a football game can do damage to your brain. So if we can avoid somebody having continued damage to them where their baseline drops, we want to do that. We want to get people help before the permanent damage, or the likelihood that permanent damage could occur, happens, because then their base level functioning drops. And if it drops too much, people eventually, that's where you see people who, if you were early enough on in your career, and you see people who come in as youth, and then that function drops and drops and drops and drops and drops. And now they don't look the same, respond the same, act the same as what they did when they first started with you. That's where you can see that. And we want to avoid that completely. If we can get people help and streamline that process before that happens, that's where we want to be. So detention under ITA law. So when we are talking about sending somebody to a secure withdrawal management facility, or a call them ENT, it's evaluation and treatment, crisis triage facilities, psych hospitals, they can all do very similar things, but the law doesn't change when we send them. It just depends on what's available to you in your community and what is the most appropriate option for that individual. So when we have detentions, a patient cannot be detained without locating a psychiatric hospital. And so that is a very frustrating thing for consumers, family members, friends, anybody who's been in this system, right? When you say, even as a designated crisis responder, I will detain them, should be detained. However, nobody is willing to accept them. Now, the problem with that is that privatized facilities can decline individuals for whatever reason. They can decline for acuity of the unit being too high. They can decline for staffing issues. They can decline for maybe they just don't want that person to have had them before, or it's too big of an issue right now to have. There is no recourse of actions for private facilities accepting or not accepting our person. So you can line this up. You can do a great job conveying this to 911. You did a great job of conveying it to a designated crisis responder. We are all in agreement that this person is better suited to be detained, but if they don't have a place to send that person, they are not legally detained. So even though a crisis responder can do it, they can't force facilities to take people against their will. So we have to keep that in mind when we're talking about locating a psychiatric inpatient unit. Okay? The other thing that we cannot do is transport them on our own. When we are talking about detentions, they have to be done by secure transport. And secure transport qualifies as either an ambulance ride or law enforcement. Now, most people, I don't want to be transported by law enforcement. How embarrassing. I probably wouldn't want to be transported by an AMR either. So even though we can say, well, it's a de-escalating thing, we'll just drive them, we'll do this, or we can find, a significant other or family member tribe. If it's a detention, they won't allow it. So that is the other thing we have to keep in mind when we're talking about detentions. How many of you have ever heard of a single bed cert or know what that is? So some hospitals will do a single bed certification. And what that means is that there has been no beds available. The DCR has called everybody in the state, and everybody that would have been able to take that person has given them a reason for declining. If you do not, and a lot of people don't, if you don't have a hospital who's willing to do a single bed cert, you have to do a no bed report. That means that I put a form to the state that says, I would have detained this person, but I'm not legally able to hold them any longer because it falls outside that 12-hour window for me to find a placement for them. I have to street them. Now, you try everything within your power, ask the hospital to admit them for a medical issue, beg and plead, but if it comes down to the person's wanting to leave and there is no bed available, you have to eventually street that person, meaning that now a detained person who should have been out there is now able to leave. If you have a hospital who can do single bed certs, or willing to do, I should say, you are detaining them to that hospital. Why a lot of hospitals don't like to do that is because you're expecting them to provide care for the person at the same level as what they would receive if they were in a psych hospital. And no real emergency department nor medical floor can do that. So a lot of times they look at that as very literal and say, we're not doing this because we can't. The only one, we have 4 hospitals in Benton and Franklin area, and the only one that will do it for us is Cadillac. And even then they won't do it for children. So you may get a facility who's willing to do single bed certs. They also have stipulations on that too. So that is one thing to find out in your area if any of those hospitals do that, because that will give you a separate option. And now you're not technically supposed to, but maybe you could suggest that they go to that hospital instead of other hospitals when there are other reasons why you would make that determination. But if we know there's going to be a placement issue and one hospital accepts and one doesn't, maybe they just find their way over to that hospital. So the other thing that frustrates a lot of people, because it is just blood and urine, is the need for medical clearance. If the person is not medically cleared before they go, the psych hospitals, ENT facilities, any of the accepting facilities will typically not accept a person without medical clearance. But like I said earlier, all that is blood and urine. So it's frustrating because now we're taking somebody to the hospital. The hospital is now doing labs, and we're only doing it for a placement issue, not because there was a medical emergency, not because there was any medical problems. Now that could apply if there's pre-existing injuries. Then you probably want somebody to get a EKG if they have a history of heart attacks, if they have any a have pre-existing history of stroke, maybe there is cause for getting that person cleared, but this is a general rule for everybody. So a lot of times we are just burdening the system and going through an unnecessary process just to get somebody placed in a situation that would be helpful for them. We talked about their secure transport. Once somebody is detained, that has switched. It used to be 3 days. It used to be 72 hours, not counting weekends or holidays. In Washington State, that has now switched to 5 days. So 120 judicial hours, meaning that no weekends or holidays count in that. So sometimes you can really make people mad when I detain you on a Friday, Saturday and Sunday don't count. Monday is a holiday. Now you're looking at potentially Tuesday being the only one that count, Wednesday, Thursday, Friday, you're still in there for another weekend then. So sometimes that can really upset people, and hopefully there isn't any of those adverse effects that we were talking about, where that 5-day stay has now led them to get dropped out of college or lose their job or have other issues. So we have to keep that in mind on the length of time that person potentially is going away, and then even further after that. So here is, for you guys in the recovery community, something to know about. A lot of our secure withdrawal management facilities have gotten waivers that they will not do seclusion and restraint. They will not do 24/7 med management. And so if you get somebody who is not pleasantly intoxicated, you get somebody who's a little bit more difficult, mouthy, maybe posturing could be interpreted as aggressive. The secure withdrawal management facilities aren't going to touch that person. They are going to then burden the medical, or I should say the behavioral health side, the psychiatric hospitals, because they will take them regardless of that. Where if I had somebody that was overflow and my psych hospital is full, I can't send the depressed person to secure withdrawal management facility unless there is a primary diagnosis of having a substance use disorder, right? But I can send somebody who doesn't have a behavioral health disorder, but they have a primary of addiction or dependence to alcohol. I can send hospital, but I can't do vice versa. So sometimes having a secure withdrawal management facility is extremely hard to get into because of the population that they're wanting to serve. So moving on to special circumstances, how many of you guys were familiar with Ricky's Law? Ever heard of that? So Ricky's Law came out of the same concept that what Joel's Law did. However, that was back when substance use disorders and behavioral health, mental health disorders were looked at similar or different. Now they're similar. So Ricky's Law doesn't really apply anymore. It falls under the ITA criteria. The law that is different that we can use is Joel's Law. So in the past, if you called on one of your residents and you said, hey, Joe Schmo isn't doing well. Here are the reasons. Here is the issue. They come out, they evaluate, or you find a neutral location and the DCR says, sorry, they don't meet criteria. In the past, there was no other course of action. That was the only thing you could do. The only other thing you do is request another evaluation, either from that same DCR or a different DCR to see if there was a different disposition made. Then you were out of luck. Now, what Joel's Law did is give family members or people related to them, so that can be behavioral health agencies that are providing the service, that can be coworkers, that could be friends, that could be anybody, but family is probably the most likely one that file these. It gives the opportunity for an appeal to happen. So this requires two things. And this is, I'll give you the layman's term and I'll give you the legal definition. The layman's term is a witness statement. The real form is a fact to statement. So when you get online and you type in Joel's Law, there should be a PDF that comes up for you. Now, the proper way to file a Joel's Law is to print that out, fill that out in firsthand experience. You don't want to fill that out saying, my coworker, my cousin, my mom, my somebody else saw these things. You fill it out with first statement. So if you're giving that to friends, families, coworkers, it has to be direct experience. You can't use hearsay in that. Okay. So you would fill that out and then you would turn that into your local court that would handle that county's business. Now the judge then will ask two things. Joel's law applies if the DCR evaluated and didn't get the disposition that you agree upon. So now you're requesting the Joel's law, or we file, or not file, but you request a DCR evaluation and Joe Schmo bounces and he leaves, or he's now MIA and not willing to return. So the evaluation was requested but did not get completed for whatever reason. You can also file a Joe's law for that too. So if the evaluation was requested and never got done, or the evaluation was requested and we don't agree upon the disposition, we can then go through the Joe's law process, and a judge will take our witness statements and they will take Crisis's evaluation and or lack thereof and compare the two, and then the judge will make that determination on whether the person is detained or not. So that is important for you guys to know as a recovery community or recovery housing, that it doesn't just stop at the DCR. You can make your case and advocate if you have additional info that you thought was overlooked or special circumstances that weren't addressed. We can then take that and apply that later on and get a third-party decision made. So least restrictive alternatives. How we use this term, we already talked about at the beginning, is that anything is a least restrictive alternative to a psychiatric hospitalization. But we also use them in this form, which is a least restrictive alternative court order. How many of you have had residents on a least restrictive recovery order? You're on the west side, they call them LROs, the least restrictive order. So they're called LRAs or LROs depending on which side of the mountain you're on. But does anybody know or familiar with these or had residents who are on LRA court orders? Okay, well, let's talk about them then, if not. So when you initially are in a ENT facility, crisis triage facility, we're just going to use all those facilities interchangeably. When you have been detained and you are ready for discharge, the court and your providers that's treated that person there have the ability to discharge somebody on a least restrictive alternative court order. What that means is it's basically like being on mental health probation. It'll mean that you have a case manager assigned to you from a behavioral health agency, and you have a med manager assigned to you. That could be a psychiatrist, ARNP, a PCP, anybody who has the ability to prescribe psychiatric medication. Those are the two things that you have to have. Now, that case manager and that med management provider will monitor the LRA. Now, this individual, if they're willing to have therapy or they're willing to do recovery cafes or Clubhouse International models, they can have additional services. But the only thing that they can't turn down is that case management and that med management. Those are two things that have to be there present. And those are the individuals who will make the request. Either that LRA be discontinued and they can be free to go about their business, or that it continues. Now, the only time that it can be continued for are in sections of either 90, which is usually the first one. And if they've been on multiples, or you make a case that they need to be on extended, you can go to 180. So either 90 or 180 days with the option to renew. Now, you can revoke those. Okay, so that means that there are tenets in that least restrictive LRA, and they're all very similar. They're all, you should attend your med management appointments, avoid marijuana, avoid alcohol. You should be attending and avoiding suicidal ideation, following treatment recommendations, avoiding blah, blah, blah. But they're all very similar. Now, what they're not meant to be is punitive, though. So you don't get to tell Susie and Joe Schmo that are on LRAs that, hey, you need to do what I say, or I'm going to call and get your LRA revoked. It's not meant to be punitive. Now, what some people have a hard time wrapping their brain around is when I'm on an LRA that clearly states that I shouldn't be using alcohol or drugs, and I'm out on the porch smoking a joint. So I'm going to call the designated crisis responder and get you thrown back in the psych hospital. Well, if that joint didn't make the individual psychotic, it didn't make the individual hallucinate, it didn't make the individual want to hurt themselves or others, there is no initial criteria to put them into the psych hospital. So what are you putting them back in the psych hospital for? And what is the psychiatrist and the counselors treating, right? So what I mean by that is it's not meant to be punitive in nature. It's meant to be a more streamlined process to where if they are not meeting the tenets of their LRA and they are dabbling in that likelihood or that imminent danger issue, it's a slam dunk to put them back in the psych hospital. But the only other person that can do that is a designated crisis responder as well. Okay, so decompensation is often required for that to be put back or revoked and put back into the hospital. It can't just be do what I say or else. That gets back into that power struggle issue. Questions on least restrictive alternative court orders? Let's talk
I
about
have a question.
Yeah, absolutely.
Sorry, it took me a while to raise my hand and take myself off mute last time. So I do have a question. So I have had a person in one of our housing on an LRA, right? And here's the struggle I found is once they got there was a lot of communication before they got there with their case manager, what have you, they were at a psych hospital, right? Placed there by a judge.
Okay.
And then there was all this communication, and then when they got there, I had no support to help with this person, and this person was still not in a place where they were really capable of making decisions and even really functioning in that kind of capacity. So I was not able to be a very good benefit to them. And so is there a way, or is it just not a thing where they have continued support from these people once they leave and are placed into housing?
So that is a issue to where it could be two things could happen, right? One is that the person gets discharged and for whatever reason, the treatment team that's been assigned does not get the proper discharge information. So sometimes the psych hospital that discharged them on the LRA isn't the same agency that will monitor the LRA. Whatever reason, maybe it got faxed over, the emails got lost, they never got followed up with. So the assigned treatment provider has no idea that that person is now living in your home to follow up with. The other
because
is,
they were just unreachable.
Yeah, well, here you go. And here's the other one that happens. Yeah, you're following. I was trying to give the benefit of the doubt, but no, what happens a lot too is that, oh, you're in a recovery house, you have staff there. I have other people who are worse off than that. I will go focus on them. And because you're in a stable environment, I don't really have to focus on you that much, right? Now, that's BS, because if I am legally court ordered to provide, and in best practice, it should be weekly at the minimum, that I should be checking on my people on LRAs. That warrants a call to either the case management supervisor or that agency's director to state your concern that, hey, so-and-so is on an LRA. We have not seen the case manager. We have no idea when a bed management appointment is. We are not getting any information. The person is not communicating when or where they'll be at. We could even provide transportation potentially, but we're not getting any help. If there's somebody's on an LRA, that is going to require, I shouldn't say require you, the best course of action is to kick that up the ladder and start complaining. The other thing that you could do too is to look for, and some of this stuff is public record because even though it's HIPAA compliant, civil law still applies to this. So you may be able to find out who the prosecuting attorney is, who the defense attorney is. And if you're still not getting it from the agency, you can come back to that ITA court issue and present that issue to the actual prosecutor that, hey, these tenants of the LRA are not being monitored, nor are they being followed.
Okay, thank you.
Does that make sense?
Yes, it does. Thank you very much.
Yeah, so without doing the work though, and without doing the background stuff and keeping track of that, you're not going to know whether it was just basic negligence due to circumstance or it's negligence on purpose and the person isn't actually being monitored, even though they know all of that stuff that we talked about in the first one. So make sure that we're deciphering between the two and then start calling people on their BS. Any other questions about least restrictive alternative court orders? Okay. So limitations of placement. This is the other thing that drives people bonkers. So if I have a youth that is 12 or younger, we talked about this earlier, I cannot write a petition on that person. That does not mean that the help stops, though. So if you are in a youth facility or that you provide services to the youth, if there is no family attached, there's no caregiver, there is no guardian, or there is, we can still pursue detention. It just has to go about it a different route. Your designated crisis responders won't be able to guarantee that, but they can help facilitate that. So same thing for there is no Alzheimer's and dementia units. So people will say, well, they need to be on a geriatric Alzheimer's and dementia specialty unit. There's no such thing. We don't have any in Washington. I don't have any place that I can send somebody with that diagnosis to. So yes, it may, for the facility to take them, because that may be a problem with discharging to a proper facility and so on and so on. But there is no specialized unit for that to handle that. Now, same thing with autism and developmental disabilities. We used to have some diversion beds, but there is no, other than Eastern State Hospital and maybe Western State that has their own issues, but there is no specialty developmental disability place. So you'll get that a lot to where we're not curing. We talked about that earlier. At the psych hospital, I don't have a med to make their developmental disability go away or raise their IQ. Well, that's not what we're asking you to do. What we're asking you to do is to treat the behaviors that are causing those imminent danger issues, which you can by one, if they're psychotic, antipsychotics, antidepressants, anti-anxiety medications, so on and so on. That's what we're asking you to stabilize. And then we can take care of the rest, right? So there is no specialized units for that. And we'll hear that all the time as a reason for denial. The other one is there's few secure detox facilities that can manage acute and aggressive people. So worst case scenario, we get somebody who is deemed aggressive. And this used to bug me all the time as a DCR, because if you tell me, well, they have a history of aggression, I'm getting aggressive right now. I'm upset right now that you're turning this person away who needs help for that. But the issue of aggression is a very weird concept to me. I also don't like the people say, well, they're too acute for us. Well, I don't know too many prisons that can turn criminals away because they're too big of a criminal for the prison to handle. But when you tell me you're a withdrawal management facility and this person's too acute for you to handle, the only real definition of that should be that the medical issue is too severe that it cannot be treated in your freestanding place, not the fact that they're too acute in their addiction or too acute in their psychosis. That is a really strange argument to me that's always been hard for me to understand in other DCRs as well. So the other one is that this is just to get your brain working too. And 9.1 inpatient psychiatric beds per 100,000 people, Washington ranks 46th among 50 of the capacity for inpatient beds. That means that we're not the worst. But 46 other states, or I should say 45 other states, have way better resources and at least amount of them than what we do. So again, we have to keep in mind of all these things, and if all the stars align, then we're able to get somebody the help that they need. Otherwise, these things are going to be barriers that we are constantly dealing with. So just keep those things in mind. Not that they're excuses, but that is something that a hurdle that when we go back to our sequential intercept model, if we can start plugging some of these things in, like let's just say you have a 1/10 of 1% and your county is willing to fund a specialized autism and dementia area, boom, that's one thing we can plug in. If there's no child long-term inpatient, there's no clip beds in your community, boom, that's something we can plug in. So there are other ways to get around some of these limitations if your community sees it as a big enough issue that they want to provide additional funding outside of Medicaid, Medicare, and private insurance to ensure that your citizens are able to get these services. Questions, comments so far before we get into section 3? All right, I will give you another, we'll make it like a 10-minute break this time. And then we'll come back and start tackling away at section 3. All right, so hopping back on, I jinxed myself and we were talking about all that crisis. And even though I work at the ASO now, which isn't the crisis provider, we hold the crisis contracts and had to point somebody in the right direction. So I was refreshed and gave them all the info they needed because we were just talking about it. So 2 birds, 1 stone. All right, everybody had a good break. Ready to get back started? Okay, let's do it. So section 3, we're going to be covering the most common first. We'll talk about depression and anxiety and how you can address some of those with your residents. And we'll do that before we get into the more serious crisis, which is homicide, suicide, and self-harm. So we'll talk about these ones being the most common one first. We'll discuss the difference between having mental health problems, which we all have, versus having a diagnosable illness. We'll talk about the similarities between depression and anxiety. We'll talk about checking out signs and symptoms of that and any risk factors for developing or worsening pre-existing symptoms, and how to help someone who is experiencing these symptoms. This is important because when we are talking about these things, we also want to keep our depression and anxiety in mind as well, because a lot of this stuff can apply to us and our coworkers, because nobody is immune to this. And frequently we can be re-triggered when we are addressing issues that maybe we've already overcome or we kind of put on the back burner when our residents are experiencing them as well. So keep these in mind. And plus we all have friends, family members, loved ones, anybody else who may be experiencing these too. So they translate outside of our work environment too into our personal life. So what is a mental disorder? Well, like we said, we all have mental health problems or challenges. That goes with everyday life. We all have finances, we all have relationships, we all have various stressors, but how do we distinguish them between having an actual diagnosable disorder? So a mental disorder or a mental illness is diagnosable illness that is diagnosed by a psychiatrist, a physician, a psychiatric ARP, psychologist, or a licensed therapist. There are some people who can give provisional diagnosis, like a DCR, outreach workers, any first responders, and maybe even yourself that can give provisional, but they're not something that would stick, something that you would diagnose using the DSM-5. So again, it is a diagnosable mental disorder if and only if it impacts and affects the person's ability to think, their emotional state, and their behavior, and is directly related to disruption in the person's ability to work, obtain employment, or keep that employment, carry out daily activities, and these are typically around their ability to maintain hygiene, ability to sleep, ability to get up and shower, eat, those type of things. When we say daily activities, that's what we're referring to, and engaging in meaningful relationships. So they're frequently having friendships fall out, relationship breakups or divorce, so on and so on. So if somebody is having the symptoms, but they're able to maintain work, they're able to still care for their basic needs, and they're able to engage in meaningful relationships, it's safe to say that that is not a disorder, and that is a trait or a challenge they are dealing with. Now, where that goes into is if these 3 things are impacted and they have been impacted ongoing, then it's safe to say we can get that person checked out. It may be a disorder at this point. Questions on that before moving forward? Is that is important for us to know, and a lot of our rules are not to diagnose, they are to treat. So we don't want to jump to conclusions or press loved ones or family members to get help if they don't want it and these areas aren't actively impacted. Okay, so why do we raise awareness about depression and anxiety? Well, for one, it's the most common problem that people occur. Next to substance use disorders, major depressive and anxiety are the highest for reasons why somebody would seek out help. So the reason why we also raise awareness is that stigma is still a thing. It's still a thing in the community as well. I don't want to go to therapy because then that would mean that I have a mental illness, or I don't want to be seen at that clinic. I don't want that attached to me. Whatever, that's for wimps, that's for girls, that's for whatever crazy thing you could hear that has gone on through childhood or gone on through our society, whether that played out in, I don't know how many times that I watched a Batman the Animated Series and saw Arkham, and they're in straight jackets and they got padded rooms. And then I actually worked on a psych hospital and none of that stuff was there. So things get reinforced in our society, in our community, on what these things mean and what will happen to people who have these. And so stigma is still a real problem that we want to work on, is that there is nothing wrong with getting tuned up and checked out, right, for your head. You go to your PCP all the time. People go and get checked out for cancer, but nobody makes fun of them. People go and get their heart checked out or get diabetes treatment. Nobody is talking about that. But heaven forbid you go seek out some mental health treatment and somebody thinks there's something seriously wrong with you. So stigma is still there. It's getting better. But we really want to work on decreasing that stigma and not have that destigmatized, especially within our own field. Also, many people are not informed about what mental health problems are, let alone what resources are available to them. So we want to keep that in mind too, and be knowledgeable of what the resources are for those people. And professional help isn't always on hand. So maybe this occurs on the weekends. Maybe this occurs on a holiday. Maybe this occurs after hours because you work graveyards and weekends. So there may not be help available or on hand when we need it. There's also people who often do not know how to respond if they are. So we're going to talk about, how do you talk to somebody? What are the things that you look for? How to talk when things are getting difficult, so on and so on, so that you can help respond in a more productive manner. We also have people with mental health problems often do not seek help. They often go long periods of time with suffering with these issues before they decide to go in. And like we talked about with the sequential intercept model in crisis, people will typically wait until there's a criminal issue or a crisis issue before they say, okay, there's a problem, I need to go get help. So we would like to avoid that completely. If we can get somebody a help before crisis issues occur, if we can get them help before finances, relationships are ruined, before criminal activity occurs, that is the goal for us, especially in a recovery community. We want those things to occur before there are going to be consequences. So depression and anxiety, we are talking about these things together because they frequently co-occur. If a person has one diagnosable disorder, it is likely that they have another. When I have done assessments on individuals or done intakes for services, it is very rarely that somebody comes in with one diagnosable issue. Diagnosable issues often lead to additional diagnosable issues. The easiest way to think about this is, was I so depressed about my situation that now I started feeling self-conscious and now I'm super anxious every time I try to discuss issues with somebody? Or was I so anxious that my ability to perform at work or perform in a relationship or a social setting had led me to feel bad about myself, and now I'm depressed, right? Same thing goes for substance use disorders. Did I drink to help become more social and now I'm dependent on that substance, right? Or did my substance increase because I was feeling so sad and I was using it as a coping mechanism? So those are easy ways to kind of see that if you have one disorder, if it's not treated, those will lead to many other disorders. So it's typical if one has one, they have many, is kind of the thinking behind that. So we also put these two together because depression and anxiety have similar signs and symptoms. And what I mean by that is that you can't tease out whether somebody is feeling restless and go, that is anxiety restlessness. This other type of restlessness is depression restlessness. They're the same, they're restless, right? Same thing with difficult sleeping. Is that a cause because of your depression or your anxiety? It's a sleeping disturbance. Sleep is affected by both those symptoms, right? Appetite changes, so on and so on. So the signs, the symptoms, and the manifestation of them frequently co-occur. So you can't really tease them out that they're separate. They're often very intermingled. So there are several types of mood disorders that we'll talk about kind of here, and feel free to bring these up if you have patients that have them or want to know how to deal with them. Types of mood disorders being major depressive disorder. Bipolar disorder is one of those that can also be a psychotic disorder because it has psychotic features to it, but it is a mood disorder. Postpartum depression, That is something to think about if you are in a house that houses females or birth giving people that can or either just gave birth or are about to. So with postpartum, a lot of times you can have individuals who had never had previous mental health diagnosis, and all of a sudden they give birth, those hormones were flooded, then they were dropped, and now all of a sudden you have somebody who never had a history, never had a family history, who's thinking about suicide now because of the strange things that have gone on in the chemical. You also have postpartum psychosis that can occur. And that's really hard for a family. It's supposed to be a joyous time. You just had a baby, but the person who gave birth is now psychotic, delusional, they're talking all this stuff. And now the family is very worried. The dad's got to watch the baby by himself, so on and so on. So there can be other issues attached to that. One of those is also seasonal affective disorder. So you can see that in places like Seattle. You can see that in any of the places where we also see it in jail a lot, because when you're in jail, there's no windows in jail. So natural sunlight is out of there. So a lot of times seasonal affective disorder or seasonal depression can take place and mimic some of these that we're talking about. If we could get some vitamin D, exposure to light, get you out of that environment, or just even get you out on a cloudy day, sometimes those improve. And then psychotic disorder. So questions, comments, concerns? Okay. So signs and symptoms of depression. When we go into our doctor, okay, let's just say this, you go to your PCP and you complain to your doctor about fatigue, you have lack of energy, you're not sleeping very well, you're having headaches, maybe you have irregular menstrual cycles, you have all these unexplained stomach problems, aches and pains. What is your PCP going to do? They're probably going to run some labs. They're probably going to test you. They're probably going to want you to get a screener for this or that. And it comes back and frequently it says, hey, your labs look actually pretty good. So I don't know what's going on. And that person goes, well, that doesn't change the fact that I'm still having these weird headaches. My stomach hurts. I have all these physical pains, right? So somebody then sends them to a specialist and they go get their GI checked out, they get their head checked out, they get their stomach, whatever the issue is, checked out, and there's no major concerns here either. So now this person has just gone to the PCP, they've gone to a specialist, and there's nothing wrong, but it doesn't change the fact that they're in physical pain, right? So the one thing that we've worked with PCPs on is there is a physical manifestation of depression that you can have physical symptoms of that and it be contributed to your mental health, not to a physical problem. So if you do have patients who are saying they have aches, pains, they have these ghost symptoms, whatever they call them, and they're not being checked out properly, it's time to look at their mental health instead of continuing going down a rabbit hole of physical health. So that's one that we want to keep in mind is any physical issues. The other one we can see that are very present for us is behavioral issues. If you get somebody who normally was very social and they're withdrawing from others, or they're withdrawing from activities that they once really liked, they're frequently crying, they're neglecting their appearance or their responsibilities that they once had, they are increasing alcohol or drug use, so on and so on. These are behaviors. These are easier things for us to wrap our brain around because we can see them, right? So we have physical, behavioral. The other one that we have is psychological. And these are typically things that your residents will tell you. So they're feeling sad, they're feeling guilty, they have increased helpless, hopeless, irritability. They're frequently going back and forth between being happy, sad, laughing, mad, crying. They are criticizing themselves, others, blaming themselves for the situation, or their concentration is impaired, but worst is the thoughts of death or suicide. So those are some of the ones that when you are hearing right there, we want to do something about now. The rest, maybe we can try to, use some coping skills, do some diversionary activities. The difference between coping skills and diversionary activities, coping skills will help that person in the meantime. That's like exercise, and there's added benefits to coping skills. There are negative coping skills like promiscuous sex, gambling, drug, and alcohol. They help with the person in the meantime, but they don't add value to the or help find a solution to the problem. And then there are diversionary activities. These are things that when they're telling us about a court date, I'm such an idiot, I can't believe I did all these things. Coping skills aren't going to make the court date come any sooner, but diversionary activities are things that the person would enjoy, like going on a walk, playing video games, doing something that may not actually benefit the situation, but it's going to appease them or at least provide some entertainment value before that stressor comes back around. And you can do these with anniversary dates as well. So if a trauma was coming back around for somebody who had experienced it at a certain time of the year or a certain month, we can do diversionary activities during that, because you're not going to make that anniversary date go away. You're not going to make the stressor go away, but we can take the bulk of our time of just stewing and thinking and perseverating on that and occupy that with something that's a little bit more fun. So signs and symptoms of depression. If you were looking at these, the physical ones for anxiety, if you looked at pounding heart, chest pain, rapid heartbeat, and blushing, what would you think? Resident comes to you and they're holding their chest, they have a rapid heartbeat. They're like, I can't breathe. What do you think is happening? And it can look like a heart attack, right? The other one is respiratory. Are they having asthma issues? Are they having a panic attack? So respiratory problems. If somebody's neurologically complaining, they have dizziness, headache, sweating, tingling, I may think that is a stroke. So a lot of these physical symptoms of anxiety are going to look like medical emergencies. Okay, so the only way that you're going to be able to tease them out is with panic attacks is the length of time. Typically they peak right around 10 minutes and go away. If somebody is not and they haven't at that 10 minutes, we're looking at something else. So you can't tease these out as saying, well, that physical is not a heart attack. It's probably anxiety, depression. I would hate to make that call and then have it actually be a heart attack and the person have complications from that or worse. So you're not going to be able to err on the safe side if you do not call. So if they are exhibiting any of these signs, even though they can be signs and symptoms of anxiety, you still want to get that person checked out medically. So let's keep that in mind, that some of this stuff could be anxiety driven when it comes to physical problems, but the only sure way to fire is to make sure that they are checked out. There's signs and symptoms of anxiety, any type of avoidance situation. This could fall into obsessive or compulsive behaviors. So feeling the need to do certain activities, and if they don't, something bad will happen, or repetitive, turning the lights on and off, having rituals, doing things like that that they may do. They may be aware of those things and know that it's because my anxiety is heightened and I'm feeling more compulsed to do that. You'll find that with people who have a very good understanding of their diagnosis and obsessive compulsive disorder. They'll be able to tell you that I'm having a really hard time with my pressured thoughts or my intrusive thoughts because my anxiety is very high. And so keep that in mind too, that can't overlap into other existing anxiety kind of driven phobias, obsessive compulsive disorder, things like that. The other one is psychological. They have an unrealistic or excessive fear or worry about the past or potential future events. Their mind could be racing. They may have an inability to respond, be indecisive. They may frequently go back from being impatient, angry, and confused. They may have a lot of sleep disturbances or visual dreams. So some of these things are going to be related directly to anxiety. Now let's talk about the risk factors. And this is going to be one of those things that we talk about that you're like, of course, we all have risk factors for not only developing depression and anxiety, but worsening existing ones too. So any distressing or controllable events. We unfortunately have individuals around us that come and go out of our lives. And whether that is death or whether that is by choice, we have traumatic events that are things that we hear on the news. There are tsunamis, there's natural disasters, there are wars, there are all these different things that come and go with life that are very distressing to us, some more than others, and they're uncontrollable that we do not. So any time that we have somebody who is already having depression and anxiety issues and they're a member in your house, and we're now watching a school shooting, that may be something that we probably want to turn off or avoid without causing too much of a scene, because we don't want to add on, cause additional or worsen existing of some of that due to distressing or uncontrollable events. And that's the same thing with anniversary dates coming back around. So traumatic events, period, right? Those can be past or current sexual assaults, physical assaults, verbal harassment. They can be past, they can be secondary, they can be generational. So you have family who have been in and out of certain types of a cycle of violence, and it's just a whole generation of trauma they've experienced. They've been trauma dumped on by their grandma, who trauma dumped on their mom, who trauma dumped on them, right? Or they had a dad who abused substances and they watched a history of abuse and they have picked up on certain habits, not certain other ones, but other issues remind them of those traumatic events. So keep in mind that any type of traumatic event can be re-triggered as well. That is one thing when you are hiring peers or you yourself are a peer, we want to be very aware of where our triggers are at. So for example, we run have the contract for the Recovery Navigator program that we award to behavioral health providers to do. Part of that is employing live life experience peers. Well, if you are going to send a peer anywhere in outreach, in a homeless encampment, you're going to send them to a trap house, you're going to send them out into these various places in the community, we have to be very mindful of where those traumatic past experiences were, so we're not re-traumatizing people, and that the peers feel comfortable enough to say, hey, this is an area that I struggled with. This is something that I've dealt with in the past, so that I would maybe like somebody else who doesn't have that same experience to go out there and deal with that situation, and I will go handle this one. There is no shame in being very open and honest to what your comfortability level is on where you're doing more harm than good. So if you're going to send that person out and now they're triggered, they're going to be less likely to be able to provide good support and good help to somebody when they're really struggling themselves now. So keep that in mind. The other one is difficulty in childhood history and childhood depression and anxiety. Any past experience, right, means that you are more likely to have that experience in the future. So if you have individuals who had a history of anxiety and depression in childhood, it is probably safe to say that that will continue on into adulthood or resurface in different kind of realms and atmospheres. So ongoing or persistent stress, this could be school, this could be work, these could be medical conditions, these could be expectations, either perceived or real. A lot of times when we're getting people from the criminal justice system and they're overwhelmed by all of the obligations that they have to meet, they have to do check-in with this person, they have to do this, that, they have to meet these obligations, check in with this provider. Eventually that's going to start wearing on somebody, especially when they are coming out of that intercept 4-point and coming to you. They're used to living a structured life. Now, all of a sudden, all the responsibility is on them, right? So ongoing or persistent stress can drive somebody to worsen or develop existing depression and anxiety. Comorbidity, that's a fancy word for what we already said that we talked about, of having both a substance use disorder and a mental illness, having two different mental illness, having multiple substance use disorders. Comorbidity just means that you have multiple issues, right? A previous episode with depression and anxiety, family history, and more sensitive and emotional in nature. We all know that person who, when you hear that Sarah McLachlan song, I think it is, "In the Arms of an Angel," and they show all those puppies and all those cats, and you know somebody who's just like, oh my gosh, right? That person who's more susceptible or more emotional in nature is going to be far more likely to develop depression and anxiety issues because things are more impactful to them. We will watch a natural disaster at my house on the news, and my wife is bothered by that. And I look at her, I'm like, you don't know anybody there. You know, that's way far away on the other side of the world, but that doesn't change the fact that it's still impactful to her, right? So we do have to keep in mind those individuals who are in our family or in our work environment or that we are treating who are more susceptible due to their emotional nature. Risk factors for depression and anxiety. Illness that is life-threatening, chronic, or associated with pain. This is one of those that we, and maybe it's stigma related, or maybe it's just lack thereof, but we forget that there are individuals who were high functioning at one time. And I will give you an extreme example. I played great kids football, AAU basketball, little league, all the way from elementary school to high school with a friend of mine. Good family, supportive. He was a headstrong, smart guy. Nobody would have thought this would have been an issue. He got a job at the railroad and hurt his back pretty bad. And so his ability to work, his ability to play with his kids, his ability to get in and out of the shower, up and out of bed, he was in pain constantly, and his ability to contribute to society was affected. Well, naturally, he got very depressed and very anxious to that, right? And so the only course of action that he was given, he tried stretching, tried massage, tried chiropractic, doesn't change the fact that he's in constant pain. Well, that was back when people were just shelling out and making it rain with opioids, right? So he gets on those, and naturally taking them gets addicted, goes into the doctor and says, hey, I'm developing a problem with this. So the doc says, yeah, no problem. We'll send you to rehab. Goes to rehab, kind of comes out, says, hey, doc, completed that, but that doesn't change the fact that I'm still in mass amounts of pain. And being as educated as they are, hopefully at least these days, doc says, well, you're an addict now, so we're not giving you any of those. So he doesn't change the fact that he's still in pain, all of these things doing what he's supposed to be doing. He resorted to seeking out street medication for that, and it had some and died. And so that has been very impactful for me to everybody know that we are all susceptible of this. This isn't one of those things that there are people who are in services or people who are that you can be a healthy, high functioning adult and have one diagnosis, one medical emergency, one physical problem from being at risk factor for all of these, intentional or not intentional. So we have to keep that in mind when we're talking about some of these risk factors, that it isn't just bad parenting, it isn't bad parts of the neighborhood, it isn't how you grew up. Sometimes you could have all of the cheat codes in the world and just be dealt a bad hand and have you be susceptible to these. So again, medical conditions, recent childbirth, other side effects, lack exposure in the night, and misuse. I won't death by PowerPoint you on these, but all of these things can contribute to risk of depression and anxiety. How do you help? Well, it is actually very rare in our society to be listened to. And so listening, for one, is probably the best thing you can do. But taking that one step further is listening without judgment. So listening non-judgmentally. If you have your ability to make the person feel accepted, feel understood, and maybe there are scenarios that we can't really relate to, but that doesn't mean that you can't show acceptance, genuineness, and empathy, even if we are struggling with somebody. And that was one thing that when I brought up my history with working with sex offenders, level 3, arsonists, murderers, I would still, even though I cannot relate to those crimes, I could still show acceptance. I could still be genuine, and I could still show some empathy for the situation and how they got to the situation that they were in, even though I don't agree with those things or that I would be accepting of those acts. So we can still listen non-judgmentally, even if somebody has done something undesirable or awful or egregious. We can still assume these characteristics. So in order to do so, part of that has to be our nonverbals need to be in check. So we have to show somebody that we're actually listening, that we're attentive, that we are comfortable with eye contact. General rule for eye contact: if somebody is talking to you, you want to maintain eye contact 90% of the time. If we are talking to somebody else, we want to maintain eye contact 60 to 70% of the time, because 100% eye contact is challenging. It's a little creepy, it's a little weird, especially if it's uninterrupted. But if they're talking to us, we want to look like we're paying attention, but we don't want to be so intent that we're staring at them. So 90% is a good one. And if we're talking to others or multiple people, that's why you maintain eye contact for a few and moving on to the next. You can break that with a clipboard, looking at the clock, looking at your wrist, whatever. So it's not an intense stare, but we do want to look like we're attentively paying attention with comfortable eye contact. Okay? Open body posture. So you're not putting your feet up on the desk or your feet up on the couch. You have a open where they can see it all. You're not turned to the side or looking at something else. We're being seated. If they're seated, we want to seat. If they're talking and walking, we want to get up and talk with them, right? or being fidgety. Be aware of what you're doing with some of your, even if it is like a grounding or a stemming thing. For us neurodivergent people, we want to try to not be as fidgety talking with somebody, because you'll see in therapy, or you'll see in your house, when you have talked to somebody and you put your leg up, sometimes they put their leg up. When you do this with your hands, sometimes they do that. People will mirror who we're trying to talk to, and whether they're doing it cognitively or subconsciously, it doesn't change the fact that if we're fidgeting, they will feel that nervous injury and they will be that way too. So if we're trying to help with depression and anxiety issues, we should probably try to be as calm and attentive as possible. So how to help? We want to give insurance and, or I should say information and reassurance. Sorry, don't give insurance. But what does that mean, right? Well, one, people are used to being told what to do. Okay, and we talked about that before on when we're developing capacity, is give them the information and give them, here is what's available to you. Here's the things that can help. Here are how we contact them. What would you like to do? There are people out there who can help with this, right? We're not telling them, call this number and your problem will be solved. Go to detox, no more issues. We're not guaranteeing them. If you're telling somebody what to do and guaranteeing the outcome, you're going to be looked on as if you lied or you're unreliable. So we never do that. We give people information and instill hope in them. So we're always going to try to treat that person with respect and dignity, regardless of the issue. We're not going to blame them, even if it is a direct cause of their symptoms. We're not going to blame them for those symptoms or those consequences. And we need to have realistic expectations. When somebody is struggling with the basic needs of life, it's not like we can expect to go get a master's degree, right? Sometimes we need to start by taking a shower. We can't expect somebody who's struggling to get up and go get a job. Maybe we need to figure out how to get your sleep under control. So we need to have realistic expectations when we're talking about these things and where we're at and where that person should start, right? We also want to offer consistent emotional support and understanding, which was what I mean that, hey, if you don't do these things, it's okay. When you're ready, I will be there. How many of you know somebody that took 13 times in rehab for it to click before they started having some sobriety and abstinence, right? So if you would have said, nope, I'm cutting you off after the one unsuccessful time, this is no different. If we're offering support, showing all these things, and the person isn't receptive now, that doesn't change the fact that 3 days from now, a month from now, a year from now, maybe they will be. So we always want to be consistent with our support and understanding. We also want to give the person hope for recovery, which is, like I said, different than telling them this will solve your issue. There are people who this has worked for. There's a certain population that benefit from this. We can say things like that, that we're not guaranteeing that the person do what I say and this will be help, right? We also want to provide some practical help. So if there are things that we can do that somebody's feeling nervous, give them a fidget spinner, see if that works. If they are too overwhelmed, write a list. Let's prioritize our stuff. There are practical help that we can do now that isn't something that requires high-level education or high-level training to do. And so we always want to offer that information up to them. So sometimes what's more important is what is not supportive to do, okay? So do not tell the person to snap out of it, be reasonable, calm down. How many have ever been in a fight with your significant other and they tell you to snap out of it, calm down? Has that worked? Has it ever worked? Kind of a rhetorical one, because it doesn't. If you tell me to calm down, I'm flipping a table. Okay. This was calm, right? So we never want to do a quick fix Dr. Phil way of stopping the problem. We also don't want to be hostile or sarcastic about it. Well, I guess you weren't going to do it anyway, or do some smart little comment, or just be aggressive with it. So the other one is that we don't adopt an over-involved attitude or overprotective attitude. We need to resist the urge to cure people, right? They are responsible for self. Our job isn't to cure this person. Our job isn't to solve their problems for them. Our job is to instill good habits and qualities so that that person has an environment that they can learn to do that themselves. And that is the best way for anybody to succeed, is to be given the tools and the grace to fail, experience, try, and build self-sufficiency, and that they can do this for themselves. So we never want to overly nag or trivialize the person's experiences. Everybody knows a one-upper that says, that's nothing. When I was using, I did A, B, and C. You got it easy. we don't want to trivialize anybody's experience. If it's a big deal to them, it's a big deal to them, right? If it's not a big deal, it's not a big deal. And that's not our time to say that is a huge issue that you need to deal with. If they don't think it is, no, we can't trivialize somebody else's or compare it to ours or other people's. Yeah. And avoid speaking in patronizing tones. There's a couple other ones that I would add to that. I would also not use why as a why do you feel that way? Why did you do that? I would put what about that was the decision making or made you lead to that. One looks like you're actually generally interested in helping the person. The other one is that they have to defend themselves with a why. Well, because this, like they feel the need to describe their decision making to you versus you're actually interested in wanting to know. The other one is you. I would replace that with we. Why did you do that? Why did you this? What was your substance use versus separating issues from people and saying, let's talk about substance issues. Let's talk about usage. Let's talk about drugs. Let's talk about these versus let's talk about your drug habit, your drug problem, your drug issues, right? So if you can avoid using why and you, that also, especially in the meantime with feelings and emotions are high, that goes a long way. So we can also encourage self-help and other support strategies. These are things like exercise, any type of relaxation or meditation. These can be peer support groups, AA, NA, Celebrate Recovery. These can be other things that are more harm reduction in nature. They can be self-help books or audio stuff, YouTube, family, friends, faith, other support networks. We want to encourage things that earlier to develop good habits and good support systems that they can start tackling things themselves. Okay, so questions, comments, concerns before we get into 4. Take another break and then we will finish this up. All right, back on the home run stretch. And yes, this is recorded, and you have permission to use it as you like. And then you can always email for questions too for people who weren't on live to see it. But yeah, feel free. The information's out there, and I hope that you use it to the best of your ability. Cool. All right, so home run stretch, everyone. Deep breath. Please. Okay, we're almost there. So section 4, we save the heavy stuff for the last. So this section, we are going to be talking about what is a crisis, because how we define and how our residents define crisis may be different than how the ITA or designated crisis responders refer to crisis. So we want to clarify that when we are talking about crisis, what we're talking about and what does that mean. And then a little bit more ITA basics, so you guys can refer back to some of the stuff that we had already talked about pertaining to crisis. We want to look at how to assess self-harm and suicide. And so when you are working with somebody, what does that look like, and how can you differentiate, especially when we're working with kids? How do we differentiate whether self-harm is suicidal or whether it is a coping skill? Not a good coping skill, but a negative coping skill. But how so? We want to look at warning signs. We're going to look at protective factors. So what is already keeping somebody safe, and how do we naturally bring those up and look for them? What to do and how to talk to someone. So that is what we're going to be discussing today. Any questions on this before we get started, or anything past? Okay. All right, so the most common issues in imminent crisis that arise with depression and anxiety and traumas are suicidal behavior, suicidal thoughts, and non-suicidal self-injury. So is anybody brave enough, and I'll give you a little bit more time than I have been to answer, can anybody tell me what is non-suicidal self-injury? What does that even mean?
I don't know the correct term, but isn't it when somebody inflicts pain on themselves to kind of take away from pain, to get rid of the emotional pain?
Yes, exactly. And then the comments there, cutting, biting, burning. Yep. So non-suicidal self-injury is any self-inflicted harm without the intent of ending their life. Now, we can talk all day long. This whole training could be on why somebody self-harms, right? But that is where we want to look at it as, is this truly somebody whose harm is with the intent of ending their life, or is this a coping skill that they're using? And we can talk about that a little bit more when we lead off with the whole self-harming injury, but I want you to get that real quick focused on, is this person's intent, right? That's where we want to draw the attention and the focus to, versus, oh my gosh, they're hurting themselves. Because when it's one of your loved ones, that is your immediate response to, especially let alone somebody who we're working with. But when it happens in our own household, we're jumping. I've never had parents want to fly across the table at me when I tell them that we're not and cannot detain somebody due to cutting on their thigh, right? But to a parent, that's a very alarming. And what do you mean? My kid's clearly in crisis, they need to be detained. Well, unless you're cutting on up your wrist or on your throat or on a artery area that's going to bleed out, the likelihood of you dying from that self-harm isn't there, and we need to switch our focus to something else. And so I'll get off of that and get back on the topic, and then we'll talk about those areas on how to handle suicidal self-injury and non-suicidal self-injury, how we're going to handle those a little bit different. So reasons for self-injury. You had touched on this, Brianna, on it is any attempt to escape an unbearable anguish or pain. So when somebody is riddled with emotional pain, sometimes, or the opposite there, they have nothing. They don't feel like they exist. And sometimes when you harm yourself, those endorphins, ones that activate in your brain, we talk about the pain pleasure principle, right? So the same ones that are activated when you are having pleasure are the same ones that are activated while you're in pain. And so that's why we call the pain pleasure principle. This is the same thing that happens when you cut yourself. You get that rush of adrenaline, you get those serotonin, dopamine, all those things flowing when this happens. Sometimes it makes people feel alive. Otherwise, it's a distraction, right? Now, why we call this a coping skill is because it is making the person feel better from whatever stressor there is. But very similar to gambling, promiscuous sex, excessive alcohol or drug use, it is a coping skill, but it is a negative coping skill. It does not improve the quality of your life past the immediate release that is given to it, right? Once we're done cutting, everything, our health, our environment, everything else stayed the same. It wasn't something that we did to put ourselves in a better situation or a better environment. It did nothing for the cause of it, but it did help in the meantime, which is why it is a negative coping skill. So that's how we address whether something is a positive coping skill. Is it adding value to your life outside of just the coping skill, or is it potentially making your life worse in the negative coping skill realm, right? So it is a negative coping skill. Now, when we want to supplement that, when we're talking about self-harm, we want to focus on the cause and the reason of the self-harm. So many times parents, treatment facilities, residences will remove, okay, if you're cutting on yourself with a razor blade, we're removing all sharps. If you're hurting yourself with punching or hitting, we're going to monitor your safety. We're going to try to take away the thing that you're using to harm yourself. Now, for the immediate thing of harming yourself, that is accomplishing it. But that, if that was the one thing keeping that person safe, and you will hear that frequently when somebody says, I'm self-harming to keep myself safe. If you remove that coping skill and do not replace it or do not address the reason why, you are potentially pushing that person over the edge into wanting to end their life now. So when we do, our focus should not be on the act. It shouldn't be like, oh my gosh, you're cutting yourself, your pretty skin, you're burning your pretty skin, you're doing these things. Like, we don't want to put the focus on that. We want to put on what is it that is going on behind the scenes that coping skill is helping. Is it the fact that that person is in unbearable mental and physical pain? Is it the fact that this person doesn't feel seen, doesn't feel heard, doesn't feel anything? They don't feel control of their life. What is the self-harming doing for that person? That's where we want to put our focus on. How do we get that person to feel? How do we get that person to be seen? How do we get that person to be heard? What is it? And we put our focus on to that versus stopping the immediate self-harm. Does that make sense? Sometimes it could be to change the person or behavior. Maybe it's manipulative in nature, right? I'm doing this so that my parents, I'm doing this to my significant other, I'm doing it so somebody else will see this and maybe change the behavior of others, right? Or look at me different. It could be to escape a situation, but it never should be viewed or expressed in that manner that what you're doing is manipulative, what you're doing is negative, blah, blah, blah. So the better way to handle that is, what is that doing for you and how is that helpful, right? Again, not the why is not the use. We want to say, what about that is benefiting you? What about that is helpful? That replacing, right? And we can start asking those from a supportive environment, and we can gain much more valuable knowledge on how to help that person versus shaming them, right? So on and so on. I won't go through all of these, but these are reasons why people self-harm. Now, how to help somebody who's self-harms. One is that we're going to recognize that self-injury is usually a symptom of something else, right? Something that's more of a serious distress, physical, emotional, whatever that may be. Maybe they're trying to avoid any negative reactions. When you show them, you want to not go, oh gosh, put your shirt down, or whatever type of negative thing we can do. The best way, and I'll give you an example of self-harming, or even to a more extreme example I'll use, is when I'm trying to attention seek, right? Or I want to gauge somebody's response. So you may get somebody who Even they have a plethora of cuts, right? And they can show you everywhere. Now, the best response to that is no response at all, other than the fact to ask about them, right? If you give too much of a response, they know that they can shock you. They know they can have this value. They know that from that. So the best way is to be non-judgmental, and the best way is to acknowledge that they showed you. What does that do for you, right? What was it like to show me that? It's more of an expressing that, not from a disgust or I can't believe you do that. It's more of a, what do you think about that? Right? Like, what did that do for you by showing it to me? I'll give you an example that's somewhat related, but along the lines of why somebody would respond that way as a test, right? To show, can I trust this person? And are they going to overreact, or are they going to judge me? I was doing therapy on a young female who had been diagnosed with borderline personality disorder. Historically, she had been eating objects that was causing all types of like intestinal problems, eating screws, doing stuff. That kind of changed to harming some of her animals. And so we were in therapy, and she's telling me about treating her guinea pig like a pincushion. And I'm not responding to that. I'm listening and I'm attentive and I'm engaged, but I don't make any facial expressions. I don't change my nonverbals. And she can tell that it's not doing that. So she starts upping her story. Now, whether this is going on or not, I'm not questioning the validity of her story, but I can tell that it's not getting the same response that maybe other therapists or other counselors gave her. So she starts talking about putting the guinea pig in the microwave. And I still don't respond to this. And well, what is that doing for you, right? Like, what did that happen? What was the, so I'm asking more clarifying questions in that. Fast forward, she starts getting better and is less of a frequent flyer and starts living more of a healthy life, gets a job, is a peer, so on and so on. I see her years later on her crisis triage facility, and she sees me right away and comes up and says, you know what? None of these people here understand. You understand. Now, again, take those compliments for what they are, right? It could be misleading. It could be gassing you up, making you feel better, right, for the next thing. But she says, do you know when I could trust you? And I knew right away what I told you about my animals and you didn't judge me. And so these are the type of things that when we think, can't believe that's happening. I can't believe you showed me that. I can't believe these things. But if you respond in a negative way or a way that can be achieved negative, you may turn that person off to helping in the future, to being accessible to help, to over analyzing or over judging a certain population, that all cops are this way, all SUDPs are this way, all MSWs, all doctors. It is very easy for somebody to interpret what you did as negative and then be turned off to form of therapy or whatever it is that we were doing, just based on that reaction. So if I can stress any reactions to you the most, it is the most non-emotionally driven, more of a stoic, more of a I'll accept you however it comes, and feel free to be freaking out in the back of your mind or be disgusted or appalled or whatever it is from what you heard. But our nonverbals need to convey accepting and understanding. And that will go a long way to helping that person in the future. So discuss the situation calmly, focus on ways to stop the distress, not the self-harm, right? So these are things that we can do, like, can we figure out ways to mimic that? And can we mimic that with snapping a rubber band? Can we mimic that with ice and rubbing ice over and over? Are there other things that you can do to mimic that response that you were getting from the self-harm that will maybe do the same trick? Now, people feel certain ways about that. The self-harm is self-harm, and you shouldn't supplement self-harm with other ways of less, dangerous self-harm. But that is going to be dependent on the clinician. That's going to be dependent on the person on whether that's useful or not. So I am above I don't subscribe to any philosophy. I subscribe to the one that works for the person. So if it is working and it's healthy for the person and it's causing less damage from a harm reduction standpoint or less damage from an alternative standpoint, I am all for whatever is beneficial to that person. Right? And so do not focus on stopping the self-injury or trivialize that person, and don't withdraw treatment, affection, love, care, employment, whatever that is. We don't want to punish the person for these things. So make sure that when we are coming from that, we're coming from a non-punitive, non-judgmental environment when we're talking about a self-harm. So here's where I'm going to ask a little bit from you guys, and then I will be quiet and not ask you anymore. So when we are doing a suicide risk assessment, and it doesn't have to be one, this can be we're just answering questions, right? But we're gauging the individual. Why is gender and or sexuality matter in this? What is the reason why that would matter? What is important about gender when we're talking about suicide?
Certain genders are at a higher risk of suicide.
That's what I was thinking.
Yeah, and you're right. Sure, you're right too. Or Sherry, is it Sherry?
Yeah.
Yep. People who feel misgendered have a higher rate of suicide. That is all true, right? So this is multifaceted when we talk about gender and sexuality. So if I'm using a improper pronoun, or I'm addressing somebody or stigmatizing, or I'm doing whatever, right? So it is important to know how that person feels internally and what they identify as to avoid that. Okay. There are other stuff that comes into that where we're talking about suicide specifically in here. And then Brooke, you nailed it too, that it does matter based on how it manifests. So statistically, men die by suicide more often, suicide more often. Now that gets into also how you identify on that too, but why would that be? Why is it that men die by suicide more often where women stereotypically attempt more often? Guesses? It involves the method, the means of use. Men are far more likely to use means that there are no coming back from. Firearms, driving their car at high speed into something off a cliff. The means that men typically use are far less likely to have, they're far more likely to have the desired effect than they are to misfire, where women stereotypically overdose on pills or something that's more likely to not result and have other issues in that. So, yep. So you nailed it right there. But is it because men often use weapon and women use pills? That's exactly where I was going with that. So it revolves around the means, right? So if that doesn't mean that there aren't men who overdose by pills and aren't women who use firearms. It's just stereotypically when we start talking about statistics, that's where it will lead is the means that somebody uses, and men typically use higher level of lethality when it comes to means. So age, why is age important for you to be paying attention to?
So again, I think certain ages are more at risk of completing suicide.
Yep. You know what those two age ranges are?
I think teens and the elderly, that could be wrong.
No, you nailed it. So teens, because things are so much more impactful, right? Like, oh, I will never find another significant other, in my life. This was the one for me. And you're how old? 16, right? Oh, okay. All right. As if they're not a right swipe away on another dating app, right? Now that's easy to make fun of and see in hindsight when you're an adult and you realize that the person who you were with in elementary school versus the person in middle school, high school, college, all the way down, maybe not be the person you're still with now. That makes sense. But when I'm a young person, I don't have that life experience and that knowledge. My experiences are a lot more impactful and they're a lot more permanent, right? I'll never get over this. I'll never find somebody else. My reputation is ruined online. Oh my God. So they're far more impulsive with those things too. Now, the end of life spectrum over here on people who are retiring, or the same people that they have now have their own family that they're paying attention to, and they're less likely to come over and see how you're doing because they're taking care of their own kids now. The same people that you worked with are either retiring or potentially passing away. You are leaning more towards retirement, and your purpose for getting up in the morning isn't there. So when people's whole identity is wrapped up in what they did for a living, and now they don't do those things for a living, they have very little purpose in there, right? So the two areas that we really want to perk up to when we hear that are people who are younger and suffering from some of those issues with depression, anxiety, and worse, and the older population who are doing. Now, of course, like we said, there are outliers in every statistic. So there are people who are later on in late kind of childhood, that 18 to 25 range. There are people who are in the 40s. So that doesn't mean anything other than people who are on the far end of the spectrums are far more likely to follow through with some of those than statistically people who are not in those age ranges. Chronic physical illness, we talked about that with a story of my buddy. Growing up, you get a physical pain or a chronic condition, you get cancer, you get diabetes, you get things that you have to now compromise your life and address the whole time. Sometimes that can wear on people. So any chronic or physical illness that severely impacts your life makes somebody we have to perk up a little bit more when we're talking with them. Any type of comorbidity, so any overlying or ongoing mental illness, use of alcohol or drugs or other substances, mainly because, especially under the influence, we are far more impulsive, right? You hear horror stories about people who didn't have any issue, got drunk, got into a fight, and all of a sudden went out to their car and did something, right? That they would have, somebody said, I never would have suspected that before. Well, when somebody's judgment is impaired and they're heavily intoxicated or under the influence of various substances or a mixture of them, they may make an impulsive decision that they normally wouldn't have made outside of that. So we have to keep that in mind. The other one is lack or loss of social support. So if they don't have the support and they're often on their own, or they don't have basic needs stuff, they're far more likely to have less to live for, or they had those things and they've been removed now. Maybe they did something stupid, they committed a crime, people have backed off them, cut them off, they've burned too many bridges. So they had them at one time or never had them. Both of those can be detrimental to somebody's safety. A previous attempt, why would a previous attempt be worth understanding, knowing about your residents, and why is it something that should pique our interest?
Did you say previous attempts?
Why is that we should pay attention to?
Because if someone's attempted previously, they're more likely to complete suicide.
You are nailing these before. So whoever's been giving this to you, kudos to those, because you are on target. Anything that we have done in life, whether it was hard the first time, school, your job, speaking in public, if you have done anything once, it is easier to do again. And these are good things. They're also true for bad things. So if you have attempted in the past, you have learned what not to do and what to do next time. You have learned who to call and who not to call. You've learned where to turn to help and where not to, right? So if anything that you've done in life, let alone trying to harm yourself, if you've had a previous attempt, you are far more likely to try again and learn from that past experience. So we have to keep that in mind. Same with an organized plan. If you have put thought in anything, you didn't just stumble upon your job. You had to put some thought into it and say, okay, who is hiring and where are they hiring at? And even if that is the case, is that the area of expertise or the area of the field I want to get into? How do I apply? Do I need to put a cover letter together? Do I need to do this? Do I need to be presentable? Do I need interview clothes? Do I need to practice? There's thought that goes into developing a plan. You don't just stumble onto something, right? So same thing with the presence of suicidal ideation or plan or intent. Do they have an organized plan? If they have put the time together to formalize a plan, incorporate means, gather means, figure out things, they are far more likely to go through with that if there is a presence of an organized plan. So we always want to pay attention, is anybody under the influence? Are they, have they attempted before? And is there presence of an organized plan with means and intent? Then we're in a big time danger zone that we need to act and act fast. So these are things to perk up on and pay attention to when we are assessing somebody's safety level. And again, documenting that we called 911, here's our concerns, or we called crisis and here are our concerns. Protective factors. These can be anything. And so this is one of those where we let the person identify what those are. They can be shows, they can be anime, they can be sports, they can be rom-coms, they can be something that is so ridiculous that you think is silly. But if it's a protective factor, it's a protective factor for the person. So these are things that we want to ask, and you can ask them in ways that is more clarifying, kind of like I asked the what question, right? What has kept you going this far? What do you have to look forward to? What are things that you enjoy doing, right? Not why have you not hurt yourself? Why have you not done those things? So what is a better way of getting that out? And these can be anything. So any reasons for the person that identifies, they can be religious beliefs. Maybe they believe they will go to hell, or that is frowned upon in their religion, and they don't want to do that because of whatever in the afterlife. They can have pets that are needing them. They can have family members or dependents that are somebody that they're helping take care of. They can have work, school. These can be other therapeutic relationships that they've established, social supports, any type of hobbies. If you can identify a protective factor on something, that is a good way of steering that conversation to, rather than all the deficits, of where are all the strengths at, and getting that person to think about why they should be sticking around or what they can benefit from, so on and so on. So if you can identify protective factors, do those and roll with. So there are also warning signs outside of that assessment that we talked about on types of people or areas of their life that we need to pay attention to. These are going to be things that, regardless of anybody is saying, that we need to be paying attention to. And the most obvious one is threatening to hurt or kill oneself or others. If somebody is putting that in writing, or a song or poem, or in their journal, if somebody is speaking about that, watching repeated shows over and over, they are doing anything that is conveying that to you, okay? If you are somebody who is newer to the field or newer to this kind of issues, you may want to practice asking, are you going to kill yourself? Are you going to harm yourself? Are you having thoughts of suicide? Because these are extremely uncomfortable things to say, especially if you've never tried before. So if you haven't, we want to be able to have that be the next question and not beat around the bush with that. If somebody is showing signs that they are overtly threatening, writing, telling, that should be the next line of questioning for you, right? If somebody is seeking access to means, and this may not be as obvious, the obvious ones are guns, knives, right? But maybe they're picking up their pills, but they haven't taken them, but they keep picking them up, right? So they haven't taken any of their antidepressants. They haven't taken any of their medication-assisted treatment. They haven't taken any of their pain pills, but they keep refilling them. There may be something that they're not stockpiling them for when they need them. They stock. Same thing with sharps. Same thing with anything that could be used to, if added up, or kind of hoarding, could be used for that. So we want to pique up our interest when we hear that. Feelings of helpless or worthlessness, lack of purpose. If anybody had a purpose and they really over-identified with that, which is always bad to do, is to over-identify with one area of your life, whether that's work, whether that's a role. It's always beneficial to have multiple things. When you describe yourself, the more things that you describe yourself with, the less likely it is to it is taken away for whatever reason. So if somebody now has a lack of purpose and that's their conversation that they're kind of talking to, we want to pay attention to that. Being reckless or engaging in risk-taking behaviors, right? So if somebody was normally kind of a risk taker, but now they've upped that, right? Or they weren't at all and now they're doing things. If the person typically been in a monogamous relationship and all of a sudden now they're very promiscuous, or they engaged in kind of social usage and now they're using all the time. If they are changing habits and behaviors that are going more on the far end of danger spectrum, we need to pay attention to that. Feeling trapped can be physical in a relationship, that can be in a job, that can be in, name it, right? That can also be psychological. Okay, so any feelings of being trapped and no ways out, sometimes that is where people head, is to more of just ending it if they don't see a way out of their problems. Increased use of alcohol or drug, withdrawing from family and friends, any type of rage, excess anger, or intense feelings of revenge. Those can be something where we start getting into more of the hurting other people and then also hurting themselves, or dying by suicide assisted, getting cops to do it, something like that, right? Being agitated and a dramatic change in mood. So I want this to be on both spectrums though, okay? Because I've seen a dramatic change in mood, we always assume that the person is doing very well, they were social, and all of a sudden they're withdrawing, they're not happy anymore, they've pulled themselves away from activities, they look very sad, they're no longer warm, friendly, laughing. That one makes sense to us. We're like, oh, okay, like we're doing well, now they're not. This is a warning sign. The opposite is true too. If somebody had not been doing well for a very long time and all of a sudden they're happy and they're made peace and they look like they are calm, you would think, oh, fantastic, this person's got it together, whatever treatment they were doing is working. We need to perk up on that too, because it could be that they were struggling with these thoughts of suicide, they were struggling with life, they were doing this, and now they have finally made their determination and they're at peace with that determination. They've given away belongings, they've set things up so their loved ones would be taken care of. They've done these things to where now they're at peace. So I don't want you to completely 100% be scared that somebody's doing well. But if it's drastic in nature, they weren't doing well, all of a sudden they're great, right? Or they were doing great and all of a sudden they're not. Both of those we want to pay attention to. So any drastic change in mood, both positive or negative. Questions, comments, concerns about warning signs? Okay. So questions to ask. Like we said, the best way you can ask that question is as direct as possible. Do not beat around the bush. Do not miss the one thing I've heard people do and say, which later on it drives you crazy, is you wouldn't do that, right? You wouldn't actually kill yourself, would you? When you lead a question, okay, the person already knows that's how I'm supposed to answer the question. It doesn't leave it open-ended. It's like when you ask closed-ended question versus open-ended question. Are you hungry? Yes or no? What kind of food would you be interested in eating? Is a very open-ended question. Well, I'm kind of in the mood for Italian. I'm kind of in the mood for Mexican food. Maybe I want sandwiches. I don't know, right? Like you ask that versus are you hungry? Yes or no? So when we ask these questions, we just ask them very similar and without a leaded response, right? Are you feeling suicidal? The answer that you're going to get is going to be directly related to how you ask the question. So are you having any thoughts of suicide? Are you having thoughts of killing yourself, right? These are the best way to ask these questions because there isn't any wiggle room out of them. Give you a different response. We can just ask the back one again, of suicide. Well, I don't know. Well, are you having thoughts about hurting yourself? We can expand upon those in the same area, but right, we don't want to scapegoat out of those questions. We want the answer to that. So the next to follow up with, if somebody does say, yeah, I'm having thoughts of suicide, okay, have you decided how you're going to kill yourself? Because the how matters, and I'll tell you how that matters. For example, if we were in jail, we've asked that before, have you thought about how you're going to kill yourself? And the person says, yes, I'm going to do it, get hit by a bus. Okay. So not to make light of it, there isn't too many buses that are coming through jail, right? So is that the only way that you're thinking about killing yourself or wanting to kill yourself is in traffic? And if the answer is yes, at least that's one less stressor we need to worry about why the person's in jail. Now, we're still going to monitor them. We're not going to take that lightly. But at least if they have a specific means that is not available now, or we can learn how to kind of work around that means, that's one less thing for us to worry about, right? Same thing with, have you decided when you would do it? Okay, so sometimes people are stipulation related. If I don't get my Social Security to me, if my wife divorces me, if I lose my job, if I lose custody of my kids, if there are stipulations attached to that, we can find out where they're at in that process. Have you had your court hearing yet? Have you, when is that court hearing? If it's no other reason attached to these stipulations, we can figure out if those things are actually occurring, when they occur, and then we can help that person get help and notify the attorney of their case, notify this, that, hey, if the court case doesn't go well and they lose custody of their kids, do not allow that person out of your sight. Call the crisis unit, call these people. We can start talking and putting some plans for the future together if that's what it is. And the other one, we talked about this too, of gathering means. Have you collected things you would need to carry out your plan? This is especially important for when you are directly there with the person. If they tell you and you say, are you having suicidal thoughts? And they say yes. And you say, do you have a plan? And they say, yes, I'm going to shoot myself. And you say, do you have access to a firearm? And they say, yes. The next question should be, where is that firearm at? If it's in their back pocket, if it's in their bag, if it's in their upstairs belonging, we may now be in danger too, right? So we want to ask these questions in a fluid way that makes sense, but we can also gather the information that we need on how to properly deal with this. The other is true that if we overreact, if I'm just telling you, and we talked about this earlier, if I'm just telling you that, oh man, I wish I could just get hit by a bus, and you immediately call 911 on me and call crisis on me, and all it required was, no, I was just trying to tell you that I don't care what happens to me. I'm not going to jump in front of the bus. If I tell you that I don't care if I wake up in the morning, I'm not going to overdose on pills the night before. I'm just saying if I didn't wake up, I wouldn't care, right? So we also don't want to overreact and turn that person off to helping or asking for help in the future because we overreacted to that. So again, you're going to ask these clarifying questions in a way to where you're gathering information based on what's the best course of action, how to help this person, where they're at in the whole planning stage, and if I'm in danger as well. Questions so far on that? Okay. So how to talk with a person who is suicidal. For one, it is okay to let that person know that you are concerned about them and that you are willing to help. Okay. You can also point out observations to that person. So if they say, well, what do you mean? Say, well, I see you've given away a lot of your belongings. And normally you wouldn't give away your guitar. It's something that's pretty special to you. So that has me worried, right? It is okay versus just being like, I'm worried about you as a person and leaving it at that. If you can actually expand upon what you're seeing and what the person is doing that has you concerned, they have the ability to clarify, oh, well, don't worry about that because of this, or yeah, I actually didn't think about that and it is a big deal, and it opens the door for further conversation. But it's nothing wrong with letting the person know that, hey, I'm concerned, I'm willing to help you, and here is what I'm seeing that is very concerning to me. That is perfectly fine. The one thing we don't want to do is ask it with dread, right? You don't want to say, oh, you're not going to kill yourself, are you? Right? We don't want to, oh God, not again. You know, I've had seen correctional officers ask the question and be like, Jesus Christ, you're suicidal again? Those things aren't going to helpful, right? Or do the quick fix stuff, or you'll go to hell if you do that, right? When you start saying stuff, your kids are going to be far more likely to die by suicide too, statistically, than you, right? Some people are already feeling like a burden, feeling like that they're more of a drain on the system and that this is a better way out. So guilting them isn't going to do that. It isn't going to make them less likely to already feel like a burden. If anything, you're just solidifying that they are more of a problem and that they do have more reasons when we say things like that. So we have to keep our questions very non-judgmental. We have to keep our questions without dread. We have to pay attention to our facial expressions, our body postures, that type of thing. And most importantly, you want to appear to be confident like you've done this before. Now, that is in the back of your mind. Nobody is ever comfortable with this stuff, right? But think about it like this. If you went to get your car worked on and the mechanic's like, man, I never worked on Toyotas before, but let's throw some parts on it and see how it's going to work. Are you going to really want to go to that mechanic? If you go to a doctor and you have these symptoms and they're like, well, I don't know, it's not really my form of expertise, but let's put you under surgery and take a look and see what we find, right? Nobody's going to want to do that. You want to go to somebody who appears at the bare minimum confident, but is confident and has a skill set. So if somebody comes to you and is talking about this, if you appear to be frazzled or you're uncomfortable, they're going to be very uncomfortable, right? They're not going to feel like this is somebody who I can come to. This is somebody who's going to help me with this issue. So at the bare minimum, if you are not confident, make sure that you are faking it on the nonverbal situation and go ahead and freak out in the back of your head and wait till after we put this person in the right spot or point them to the right resource, that then we go talk about it with somebody else and express that, because you're never going to feel 100% comfortable. Oh, I got this. Suicide is my specialty. No worries here. It's an uncomfortable thing. It's not something that we're dealing with that we're going to ever feel 100%. Yes, this is my realm of expertise. Even when it is, it's still a very special, individualized thing for a person. It's not, I've dealt with this, I've dealt with them all. They're all different. They're all unique. Everybody is, has their own kind of interpreting things and their own perspective on things. So it's always going to feel uncomfortable for the clinician or the person helping. So there are other two areas that we definitely want to pay attention to and look at from a risk perspective. And that is, we talked about this one, are they on alcohol or drugs? Because that may increase the inhibitions or decrease the protective factors that were already there. They're going to lower that. They're going to be, could happen with that. And it could be non-intentional, right? It could be the fact that maybe they have been abstinent and been sober for so long and their tolerance has lowered. And now they pick up and use the same amount that they used when they were active in their addiction and they overdose. It could be that they are relapsed and they are looking for, stuff off the street and they don't go through a reliable source. And there's fentanyl or there's something else that's mixed with that shouldn't be mixed with that, right? So it could be intentional, it could be non-intentional, but both, whether they're actively using alcohol or drugs, is going to be a warning sign for us. The other one is that past attempt, and we talked about that in the last slide. If somebody has an organized plan or they've attempted in the past, they're far more likely to do it again, let alone learn from the past on what to do differently this time. How do we talk to a person who is suicidal? One is that we listen non-judgmentally. Remember, we talked in the past one that you need to have the nonverbals of somebody who is paying attention, but not overly involved. We don't want to be dramatic with our responses. We don't want to be crying as well. We don't want to be showing shock or being appalled or disgusted. We really want to listen like we're trying to help the person and seek out what they think is the issue. Non-judgmentally is both with your eyes. It's looking for empathy. What is the difference between sympathy and empathy? I told you I wouldn't ask you again, and I did, but. So sympathy is, I feel bad for you. I feel sorry for your situation. That sucks. Empathy is, I put myself in your shoes and feel what it would be like to be that person. So this listening judgmentally is very much listening with empathy. You're listening for heart, you're listening for meaning. What would it be like to say that? What would it be like to be here as a resident in this house and telling me that? What would that feel? Versus that sucks for you in that situation. It's terrible. That is sympathy. Empathy is, I can try to understand what it would be like to being out of my comfort zone, losing my significant other, losing my ability to maintain or care for my children, losing my job, losing these things. What would that be like, right? That is completely different than feeling sorry for somebody for their situation, and that sucks. So the other one is we want to make the person feel respected, accepted, and understood. So how many of you Maslow's hierarchy of needs, I'm sure you've heard of, right? Well, at the bottom of those is your basic needs. So food, water, shelter. So outside of that, most people really just need to feel validated, appreciated, understood, and are things that we can give them. I can't give you a shelter. I can't give you food. I can't give you those things all the time. Sometimes I can. But the one thing that doesn't take any problem is for me to be genuine, me to be accepting, and me to make you feel validated and understood. And the problem a lot of times is we think that even if it's something that is egregious or something that we can't, you can still validate somebody without accepting what they're doing, right? Maybe it's to support their habit and they're doing these acts, right? Maybe they've been trafficked. I had to learn how to validate a sex offender, a racist, right? Different people whose stuff that you do not subscribe to, you do not agree with, you may even find completely disgusting, but we can still validate somebody's experience on how they came to those conclusions, even when they are undesirable. And this is one of those. So if somebody is truly suicidal, and regardless of how you feel about suicidality or ideation or the consequences of such, you can still make that person feel validated and still feel like they're understood without agreeing with the acts that they're doing. So again, some of those nonverbal skills are going to be your attentive and that comfortable eye contact and open body posture. I made a mistake one time when I was doing therapy, and I did this. And I was doing therapy on an individual who had just been released from prison. He was kind of getting back into the swing of things, because we talked about this being in jail or being incarcerated for long periods of time. It's very structured, right? So when you get out and you're responsible for getting to your appointments, getting this paid for, setting this up, it can be very overwhelming. So he was kind of dumping on all of that, and I did this. And I won't go into 100% quotes on what he said, but he said, "Man, F you." And I went, "Huh?" I did one of the Scooby-Doo things. Oh, didn't understand. And he went, "Man, F you." And I'm like, what happened right now? And he's like, "You don't give a crap. You don't care." I'm paraphrasing, right? He was not very happy. And he's like, "You're done. You're done listening to me." And I looked down and was like, oh, like I crossed my arms, and he took that as like, I'm just here, just going through the motions. And I had to relay some personal info because I felt like it was more. I'm like, no, I actually have AFib. And when my heart does that, this is more comfortable for me. But it took that much of a nonverbal cue that he was expressing all of these things to didn't want anything to do with me, right? So the slightest little kind of that we're not really thinking about in our nonverbals can really lead somebody to trust us and divulge stuff to us, or completely withdraw and want nothing to do with us. So try to keep those in mind. It's not ever going to be 100%. You're never going to be great at it. You need to give yourself some grace that you're going to do something nonverbal to make somebody mad. Maybe you eye roll, maybe you roll, look away. Whatever you do, people can interpret that. So try to be mindful of your nonverbals when we are talking to people who are suicidal. So professional help. This is where we want to give somebody the information, but not tell them what to do, right? So when maybe they are needing some type of professional treatment, we can let them know what that information is. There are doctors available. These doctors can be PhDs and be more theoretical and more of less of a medical doctor and more of somebody who is in behavioral health. They can be primary care physicians, psychiatric A&P. Some people like dealing with nurses who can do the same thing the doctors can. They have that higher level of education. They feel more approachable. They don't God complex. Stigma is real and people carry that. So what do they think? Do they not want to talk to the doctors? Well, A&Ps can do the same thing. So can physician assistants who work under medical doctors, right? DNPs. There are other options for people who can prescribe meds that if somebody doesn't like doctors or had bad experience with doctors, that they can go with someone else. Same thing with psychiatrists. If because A&Ps can either be physical, they can primary care-ish, or they can be psychiatric. Two different specialties, two different routes. So if they don't like psychiatrists, they don't want to talk to, I've heard people say, I don't want to talk to that quack. I don't want to talk to this. Well, would you be more comfortable talking to a nurse? Maybe they would, but little do they know that nurse can also prescribe medication for you. So that may be something. Social workers, licensed therapists, the big one that we are pushing all over and in every field is certified peer specialist. I know that title is changing and will change. It won't be certified peer specialist anymore. But that doesn't change the fact that I feel more comfortable talking to somebody who shares my experiences. We may not have the same philosophy on them. We may not have the same background, but it's different. And I've heard that several times when somebody says, when I talk with a peer specialist, I feel talked with. Historically, I felt talked at, right? So when you're talking to somebody who knows what it's like, that's why there's VA court who is staffed with VA, veterans who have been in it and been out of it and been in the system and dealt with that and are okay with identifying if they have PTSD or they have anxiety, depression. Feel more comfortable if that's why first responders have peer programs with fellow first responders or other officers. You always are going to feel a little bit more understood or a little bit more of understanding when it comes from somebody who has had those similar experiences. So certified peer specialists in all lines of work are being more encouraged. And then there are types of professional help, talk therapies, medication management, other professional supports. So when you are, a lot of times people want to put up barriers to why they can't get help. Well, now we have a lot more outreach and hopefully case management services that are willing to pick people up and drop them off, right? We have dial-a-ride, we have the things. Sometimes we can arrange for telehealth for people who don't want to get out of the house. So for however many barriers we have a type of professional help that can hopefully help mitigate that. And so presenting those as information versus saying, well, why can't you do that? We can do this, right? Versus we can do it via telehealth. We can have somebody pick you up. We can arrange for a dial-a-ride and get you services that way. We can allow you to go, whatever that is. Or maybe some people actually even come out to the house now. We have several co-responders that in Pasco that will actually come out to the home. We have a med provider who would do the same, that will come out to the house. And so sometimes people are working on different ways and out of the box ways of thinking to handle something that would normally be a barrier and prevent somebody from seeking out those helps, that we can find some wiggle room or a way around that. So how do we provide reassurance and information? Okay, so very similar to some of those other slides that we talked about, we do not want to blame somebody for their current state. Well, if you had just kept your job, if you had just didn't use, if you didn't commit that crime, if you didn't, those are not going to be helpful, and that never is helpful. It's not helpful in our personal life, it's not helpful in our romantic lives, and it definitely won't be helpful in our professional lives. So trying to blame the person for their state or symptoms, I'm pretty sure they know that, right? It used to drive me crazy when I would get somebody who has that Dr. Phil quick fix, right? Like, have you ever thought about not using meth? I'm pretty sure that the person who is using meth has thought about not using meth, right? So telling them that their use of meth is leading and causing all this, and if you just stop using meth, you wouldn't have these problems, is really not that simple, right? I'm pretty sure they have thought about not using before, okay? So blaming somebody for that and having quick fix solutions is really just making us look like, one, we don't care, and two, we're not very smart either, because I'm sure people have thought about the most obvious option, which is to reduce, at the bare minimum, stop their usage, right? So that's where we need to have more realistic expectations, offer emotional support and understanding to that. Realistic solutions may be that we don't have abstinence sobriety, and that harm reduction is maybe a more appropriate, at least interim spot to get to the sobriety and abstinence, right? So maybe we need to work on decreasing the amount of usage. Maybe we need to decrease the amount that they are actually using, let alone the time between usage, right? So we can start focusing on other areas or presenting that as options to the person to see if they're willing to try those things, because maybe they're not willing to just shut it off cold turkey and stop 100% completely. That is also a problem that we have for a lot of our housing resources, is that, and this is across the state that I've come from what I hear, we have lots of faith-based programs. We have lots of sobriety and abstinence requirements. We do not have a lot of middle ground for people who are wanting to stop, but due to the consequence are being kicked out for their ongoing usage, right? So if we had back to that sequential intercept model, even if we did have houses, because we need that, we need consequences for some people. Some people aren't going to change if they didn't have a consequence. And some people need faith and some people need abstinence and sobriety. There's nothing wrong with those things. But there are a certain population who are homeless or out on the street or in certain circumstances because the resources that we did have were all or nothing and they weren't ready for that. So if we can start plugging in some harm reduction models, some safer usage, different things like that we can provide those information people who want to choose that, they'd be far more likely to succeed. And then we have another avenue to venture off and transition from that service line to this service line. And what isn't supportive? Okay, we talked about that being very quick fix, snap out of it, calm down, be reasonable, be smart, do the right thing. None of these things are helpful. Okay, that is going to just make the person want to flip the table, right? I don't know too many times that I've ever told a significant other, or they've told me, just be rational, calm down, like think about this. Those things aren't going to help. They don't help you. They're not going to help anybody else, right? Again, belittle or dismissive. And I cannot resist that enough to not be overly involved, to treat everybody the same. And we don't want to devolve an over-evolved perspective, but we have to be real with that. There are people who are going to push our buttons and bug us for whatever reason. It's their face, it's how they talk. They remind us of somebody who abused us. And there's going to be the opposite. There are going to be those people who pull heartstrings and we identify that person. We want that person to succeed. We want them to feel better. We want them the best for them. And so we want to go above and beyond for that person. Be very careful and also do your own work on why that is on both ends. Why is it that I dislike this person? And why is it that I'm really drawn to this person, right? That is something that we kind of need to do our own work with, that so we are stay in that middle ground and be a very objective clinician versus subjective. So this is back to that, what is that crisis? Because I know it used to really drive community members crazy, community partners, when somebody would call in crisis. And this is maybe even another therapist, a housing program. This is maybe the jail. This is somebody who's saying, hey, we're in crisis. This person here is in crisis. They're in need. And what they hear on the is, well, that doesn't fall into the criteria. We're not going to help them. Crisis doesn't involve the criteria. Crisis is self-defined. So if I'm telling you I'm in crisis, I am in crisis. We don't have to respond the same to each crisis, meaning that if we were in a similar situation, I may interpret it completely different than you interpret it. But if I'm telling you that I'm in crisis, I'm in crisis. And we can think about this and use the example of, on an extreme example, me and a coworker shared a similar client. We had two different jobs, but it was our client. That client murdered another one of our clients. Both of us were there. Both of us were, but we both experienced that same stressor completely different. My level of crisis from that and my level of ongoing interpretation and trauma and all the other stuff that occurred from that was different than the same person who witnessed the same thing, right? We both had two different experiences in that. Me telling that person that their experience wasn't valid because they should be responding this way, you can see how that doesn't make a lot of sense, right? So why would it make sense that we would tell somebody, oh, no, you're not in crisis. This is a crisis. This is actually the real crisis that happens, but your crisis isn't the real crisis. They're still experiencing that crisis. It may be minuscule to you. It may sound silly to you. It doesn't change the fact that they're still in crisis. So that is something that we as clinicians, we as community partners, as peers, whatever our roles are, that if somebody is coming to us in crisis, they're legitimately in crisis and we need to treat it as such, right? So it is self-defined regardless of what the criteria or the law says. So any intense, difficult, troubling, or dangerous situation, that is a crisis. They can be real, perceived, or not based in reality. That is the other thing that too much people get caught up on, is saying, well, that's actually not true. And here's why it's not true. So therefore you shouldn't feel that way. This doesn't have to be based in reality. It doesn't have to say 1 + 2 = 3. It can be 1 + 2 = 9. It doesn't matter if that person perceives it to be a crisis and perceives it to be true. It is true. So again, get that real quick out of your thoughts, that if it's real, perceived, or not based in reality or criteria, it can be any one of those three things, right? So how a designated crisis responder looks at crisis is going to be strictly related to the criteria. Now, hopefully they are more intelligent in nature to know that doesn't change the person's criteria, and what they are explaining is around the law. And the law interprets, I can take your rights away under these sections. You are a danger to self, danger to others, or you are gravely disabled. Not that you are in lack of crisis, right? So hopefully that is how things are being explained. And when you are advocating for your clients, or you're advocating for these, that you're speaking to, here's what the crisis is. And if we are needing it, here's how this is resulting in imminent danger, likelihood of imminent danger. They don't have volitional control. They have had a history of this, right? We can start using these things that we've talked about in here to paint a picture that we've tried these safety plans. They don't have these protective factors in place anymore. They've actually lost all their natural support. We're utilizing all these things that we talked about to paint a better picture, so that if it does fall out of these things, they can still make the case for, now I know why you're calling, because these danger areas are present. These warning signs were present. They don't have any least restrictive alternatives. They don't have any safety plans that are actually plausible or doable at this time. We're able to paint that picture that makes sense to the person who's doing action, who knows, okay, that's my course of action, and I have this collateral information to go off of. So I tried to get it within 15 minutes. So I was almost there. I'll give you like at least 13 for any questions, comments, or concerns. So anything that you discussed, anything outside of that. I know it was a very long day. We talked about the sequential intercept model. We talked about when determining capacity and Involuntary Treatment Act. We talked about depression, anxiety, and then all of the crisis situations. So with all of that, or outside of that, just something else besides, any questions or comments, stuff that you want to discuss or required further clarification?
I just wanted to say thank you. It was such a great presentation, and I know it will be nice to have this video and the slides as a resource to where you can even reference back to something that you talked about, because it was just so many good things. And I know my brain only absorbs so much an amount of time, so going back to it will be really helpful, and we will have this as a resource for you guys as well, to go back on.
And besides having my own consulting and training company, I also work for the ASO. So if you do have any concerns with crisis, you can always reach out to your local ASO, and they are the ones that monitor and audit those services too. So
I also wanted to say thank you. I got a lot out of this. I took you in my car with me when I had to go somewhere. And I'm looking forward to going back and getting all the stuff that I missed. But I also want to, I've never heard anybody be able to do what you did 5 hours with just a few 10-minute breaks in between, and keep it that on task and
really interesting,
informative. Yeah, it was great. It was really great to listen to.
Mm-hmm.
Thank you.
thank you. All right. Well, I would love to be back and do it again. if you want me back or expanded upon that. I know it's summer, so people are out and about wanting to be in the sun. So understandable.
Yeah, definitely. I'll have you back, Cameron. Okay, well, everybody have a good day and be on the lookout probably next week for the resources and video.
All right. Thank you much. Have a good one.
Thank you.
Thank you.